look at his. Yeah, you can. That's good. That's good. Yes, you can start now. You can move it. Can you start? I mean, just a few slides.
Okay, okay.
Move few slides. That's it. Okay. That's
Is it
right.
okay?
Lovely. Excellent. It's all right now.
Okay.
That's great. Nice. So you can stop sharing. And
Okay, sir.
Doctor, okay. Dr. Golam Kadir is there, and we have 18 participants at the moment. Great. And is Dr. Ben is around?
Professor Taya Afghani.
Hello,
Listening.
welcome. Welcome. I can't see you on the screen. Just wanted to
No, we
say
can
hello.
see has a good photograph.
Oh, great.
Good
Good.
evening. Good evening.
Yeah, he
Good
is one of
evening.
the smartest ophthalmologists, mashallah.
Thank you, sir.
Thank you. Yeah, good. So, Doctor, we are waiting for, I think, is Dr. Santosh Honavar around? Dr. Grover is around? Dr. Abrar Hussain, welcome.
Assalamu alaikum, sir.
Wa alaikum assalam, Mahin, welcome.
Thank you.
Dr. Abrar, can you hear us?
Yes, yes.
Okay,
Assalamualaikum.
great.
I can hear you.
Assalamu
Thank you.
alaikum.
Thank you very much.
Assalamu
Thank you. Walaikum
alaikum.
assalam.
That's great. And so, Dr. Saad is, I think everything is all right on your side.
I think Dr. Ghulam Haider is online.
Yeah, he is already, we have just said hello, and
Mhm.
he is there. Dr. Demirji is there. Dr.
Yes.
Online. I'm online. Inshallah.
Yeah, he is there already. He is just off
Great.
this, just he is keeping him,
Great.
I mean,
Great.
he's ready, you
Great.
know. Yeah. So I hope, Dr. Ghulam Haider, how is the situation in your country regarding COVID? Dr. Ghulam?
About OPSA, about what about that?
I asked about the COVID situation, the corona situation
Oh,
in
who's
your
in
country.
Bangladesh? In Bangladesh.
Yeah,
Now average 25 died every day. 25.
25 what?
25 died every day.
Okay.
Per day 25 died. Per day. Average.
Okay.
In Pakistan?
Pakistan is around 80 to 50, between 50 to 80 deaths daily at the moment. And our positivity rate is around 5 to 6%. But it is, the positivity rate is, alhamdulillah, improving now. It was around 10% about 2 weeks back. Now it is around 5 to 6%. But let's hope that we have passed the peak of the second wave. But I really don't know. It is, corona is really very unpredictable.
All are from Almighty Allah subhanahu wa ta'ala.
Okay.
All are from Allah subhanahu wa ta'ala.
Yeah.
We have to pray to Allah
Yeah, of course.
for mankind.
Oh, yeah, of course.
I have two slides.
We are actually, I think our friends from India, they have yet to join, but all others participants from Nepal, Bangladesh, USA, and Pakistan have joined. And the panelists and participants. We are waiting for our friends from. That's up. ED. Okay, Dr. Saad, now can you hear me, everyone?
Yes, sir. Sir,
Okay, I had a telephone call from one of the audience. He is an ocularist. He was asking whether he's very senior most ocularist, in Pakistan. So he joined us, and he was just wondering whether he can be seen on the screen. I thought I don't know what I think. I told him that it is not possible. Only participants, speakers, moderators are they can be viewed on the screen. If you have any question or comment, you can put it in the chat box. Is it right?
yes, sir. You are absolutely right.
Okay. Dr. Demirji?
Yes.
Hello?
Yes, can you hear me?
Yeah, I can hear you.
Okay.
I was just wondering, how is your situation in Kellogg and Michigan about the COVID situation?
I think we are coming towards the end of the second wave is coming down right now. It come down very much.
Okay.
But
Good.
of course, this is the New Year time, and then people traveled a lot right now. We will see
Okay.
after what's going to happen in the next couple of weeks.
Yeah, you're right. You're right.
And then the vaccination started for the physicians right now.
Okay. Did you get the vaccination?
I didn't get personally. I'm waiting on the line right now.
Okay.
But some of my colleagues starts to get it.
Okay. Okay.
Yeah.
You are you are certainly in favor of getting the vaccination, of course.
Yeah, that's true.
Because there are many people in United States, they are not, and elsewhere as well, that they are rather confused about.
Yeah, it's going to take time. I think it's going to be take time. We shall see.
Yeah, you're right. And how is how are you regularly visiting the clinic and seeing the patients?
Mm-hmm. Like we closed the clinic from we didn't close. We just turned into only the emergencies from March to the July or something, end of middle of from March to the somewhere beginning of the July or something. We only see emergencies.
Okay.
Because of the tumors, I didn't I slowed down, but not that much.
Okay.
We still see the cancer patients as a kind of an emergency. After July, we are almost full speed right now.
Okay. Okay.
Yeah, we are full speed since July.
Great.
So it's everything back to normal when you were here.
Thank you very much. Yeah, that was a very nice time, we had with you and Alan Kahana. Alan is all right?
Yeah, he's all right, but he left Kellogg right now. He went to private practice.
Okay.
Yeah, he's in Michigan still, but he's in private practice right now.
Okay.
Yeah.
Professor Nelson is all right.
Yeah, he's all right. Yes.
Okay. And I'm just forget Elner. Yes.
Elner,
David
yeah.
Elner.
Everyone is good right now, Dr. Elner. And then we expanded 2 more new faculty, and then now we are maybe hiring another one because Dr. Kana left, Alon left.
Okay.
So we'll see. That we will expand a little bit more.
And good. That's great.
Yeah.
Dr. Friha, how are you?
I'm fine. How?
Okay, great. I hope this time your mic is working now. Maheen?
Yes, sir. Sir, it's something went wrong with the video, but it's fine now.
Okay, great. Maheen, are you around?
Yes, sir, I am.
Yes, okay. I hope you can check your mic and all that.
जी सर आवाज आ रही है आपको?
हाँ जी बिल्कुल. We are hearing you. Yeah.
Yes. We did a check before. Yes.
Welcome, Dr. Moin. Dr. Moin has joined from Pakistan. And we're just waiting for Dr. Grover. Dr. Santosh and Dr. Grover. Assalamu alaikum, Dr. Moin.
जी वालेकुम सलाम, क्या हाल है? मेरी आवाज
चेहरा
आ रही
दिखाओ
है?
ना जरा, चेहरा तो दिखाओ तुसी किथे हो.
एक मिनट में जरा उसका आपका वर्चुअल बैकग्राउंड जरा सेट कर रहा था.
अच्छा. So at the moment we have attendees and panelists there. Just about few minutes left before we start it officially. I hope Dr. Ashok Grover joins us in time.
जी सलाम. बिल्कुल ठीक-ठाक है.
बहुत चलो ठीक है.
जी.
सारा सेट, मैंने कहा सेटअप सारा मौजूद है माशाल्लाह. लुकिंग वेरी गुड.
Alhamdulillah, thank you very much. But I can't see you.
नहीं मेरी चल रही है, आ नहीं रही.
Okay, let me see. Maybe I have. Yes. No, yes. I can see.
Assalamu alaikum. Yes, Dr. Moin, we can see you. The video is there.
But your still is there, not yourself.
मेरी पिक्चर नहीं अच्छा
Still
अच्छा नहीं लाई थी I don't know,
photograph is there. Yes. Yes.
अच्छा इधर से तो आ रही है
Yeah. Now you are now there. You got it here. Yeah, here you are. Welcome. That's great.
Good to see everybody. Dr. Mehboob Kader Lambu, how are you?
Yeah, he's there. Dr. Ghulam Haider is there. Dr. Mehboob Al Qadir is there. Dr. Hakan Mirji is around from USA. Dr. Ben Limbu from Nepal is around. So we are waiting for our friends from
Dr. Moin is there.
Dr.
Yes.
Grover.
Assalamu alaikum, Dr. Moin.
Walaikum salam. How are you, Dr. Ghulam?
Alhamdulillah.
Good to see you.
Alhamdulillah.
Yeah.
Alhamdulillah.
Thank you very much for joining.
Doctor, he was the first one to join, I think, Dr.
Acha.
Ghulam Haider, yes. Very particular in time, mashallah, always.
Alhamdulillah.
That's great. Okay, so what do you suggest? Should we wait for a couple of minutes at 3 o'clock, or should we start with Dr. Wait for Dr. Ashok Grover, or we should start?
I think we can start because it's going to be 2 hour, 3 hour long, I think. Or you can, somebody can call him on the internet on WhatsApp and then check. Sadullah probably can call him or send him a message on WhatsApp to send him a reminder. Maybe it's because of the time zones.
Yeah, we are close to the time.
Probably you can give him a WhatsApp call.
Yeah. Mhm. Hello? Dr. Grover, it's Dr. Afghani from Pakistan. Hello, it's me, Dr. Afghani, Dr. Tayyib Afghani from Pakistan. We have already about 36 participants at the moment, and the number is growing. Actually, before we started, we have around 95 registrants. We are almost registered to the capacity, mashallah, in this webinar. And I hope so. Hello? Dr. Grover, it's Dr. Afghani. Are you around? I'm fine. We are waiting for you at the webinar, actually. It's okay. Please, can you also ask Dr. I hope Dr. Santosh, you can remind him as well. You join us, and then afterwards, because we are waiting for you to start the webinar, and then we will go ahead with the. No problem. No problem. Please join. Okay. Yeah. Their link is sent today as well. And you can just click the link and join via Zoom. Yes. Let me know if there is a problem. He will be joining in a minute. Dr. Grover will be joining in a minute, and then welcome, Dr. Amir Yaqub.
Thank you very much. Thank you very much for inviting.
Assalamualaikum, Dr.
It is a
Amir.
pleasure
Good to see you.
Yeah, it is a pleasure to join such a elite gathering of oculoplastic surgeons from around our region. And looking forward to a good meeting.
Inshallah. डॉक्टर माहीन, ये आप थोड़ा सा सेंटर करें, आप अपने आप को सेंट्रलाइज करें उसमें. हाँ, यस, अपने स्पीकर, अपने वीडियो को ठीक करें जरा.
अब ठीक है? Is it all right now?
Yes. Yeah, it's all right. Waalaikumsalam, Sadullah. Dr. Amir, we are just waiting for the president of the Oculoplastic Society of South Asia.
Okay.
Dr. Grover, I just talked to him. He will be joining in a few seconds, I think, hopefully. Dr. Amir, we are just waiting for the president of the Oculoplastic Society of South Asia. Okay. Dr. Grover, I just talked to him. He will be joining in a few seconds, I think, hopefully. Dr. Saad? Dr. Amir, for the president of the
yes, sir.
Oculoplastic Society. I am having a recording of my own sound afterwards. What's happening? It is. I'm just listening again to my.
We are also listening twice. Yes.
Yes, sir.
I am having a recording of my own sound afterwards. What's happening?
Sir,
I'm just listening again to my.
We are also listening twice. Yes.
सर काइंडली अगर कोई यूज कर रहे हैं YouTube की वीडियो या कोई और अपने साथ डिवाइस है तो उसको काइंडली ऑफ कर दें. सर काइंडली अगर कोई यूज कर रहे हैं YouTube की वीडियो या कोई और अपने साथ डिवाइस है उसको काइंडली ऑफ कर दें.
Okay.
Dr. Tayyab, if somebody from the audience want to speak with panelists, so shall we allow at the end of the session or in the end of the presentation during question answer, or they can only write up their question on or query?
Well, it depends on the time as well. It's better to at the end of each we have planned a few 2 minutes to about 2-minute discussion after each of presentation, and some it is more than 2 minutes. So it's better if you write down and they write down the okay, because otherwise many people will like to, or they should raise hand. There is an option for raising hand, and then
yeah, that because one of the attendee has raised the hand. I don't know.
Okay.
Was it by mistake or something? Okay.
I think
we should start.
Good afternoon, everyone.
Okay, Dr. Grover, welcome.
Sorry for the delay.
No problem, no problem. We knew you might be stuck in somewhere in New Delhi. It is. I hope it's not. There is no lockdown or anything like that, and there's no rush.
No. Fortunately, the situation is better now, and we have much fewer cases.
Okay.
But it's a very nice winter, chilly day with a lot of rain this morning.
Okay, good. We have also rain in the morning here in Islamabad.
Good.
Yes, it's quite chilly.
Winter rains are welcome.
Yeah, you're right. Okay, if you allow, should we start? It is now.
Yes, we should start.
10 minutes late, yeah. So, welcome everybody, all the participants, all the panelists. We have at the moment 12 panelists who have joined us, and there are around 43 attendees. So already we has a quite crowded room at the moment, and that's a welcome sign that people have interest in this rather rare specialty in ophthalmology. I welcome on the behalf of Pakistan Oculoplastic Association all the participants, Dr. Ashok Kumar Grover, Dr. Professor Muhammad Moeen, and Dr. Amir Yaqub, doctor from Pakistan, and Dr. Ghulam Haider from Bangladesh, Dr. Sayyid Mehboob Abdul Qadir from Bangladesh, Dr. Ben Lempu from Nepal, and also we have Dr. and not from USA, Dr. Hakan Demirji. He has all the way taken his time, and he's got up early in the morning. We are really Grateful to Dr. Damirji. Thank you very much. So, and all the attendees, and they are already there. So we welcome you all to this joint venture of health education and professional development program on behalf of Pakistan Oculoplastic Association and Oculoplastic Society of South Asia. I am the president of Pakistan Oculoplastic Association, and we have two past presidents with us from Pakistan, Professor Moin and Professor Amir Yaqub. And we have our very worthy president of OPSA, Oculoplastic Society of South Asia, Dr. Ashok Kumar Grover, very, very well known in the circles of oculoplastics and ophthalmology. So it's an honor that we have him around. So I will start. First of all, now I will give you a small introduction of Dr. Grover, and then I will request Dr. Grover afterwards to start the proceedings. Stop share. I will again have to start sharing. So Dr. Ashok Kumar Grover, as a formality to introduce him, everyone knows him very well. He is the recipient of one of the highest awards from Government of India, Padma Shri Award, and he is currently Chairman, Department of Ophthalmology, Sir Ganga Ram Hospital. He is President of the Oculoplastic Society of South Asia, which is the main host of this webinar, and he is past President of All India Oculoplastic Ophthalmic Society and Asia Pacific Society of Plastic and Reconstructive Surgery and Oculoplastic Association of India. He is author and editor of 4 books and over 100 book chapters and 60 publications. This is just small part of his CV, which we could accommodate here. So thank you very much, Dr. Grover. I request you now to, sorry, we can just start again. Okay.
Thank you, Dr. Afghani.
Yeah. Please, Dr. Saad, can you stop this? My screen, okay. I have to sorry. Okay. Okay. Please, Dr. Ashok, Kumar, you can just start the proceedings now.
Good afternoon, everyone. It is wonderful again to have another program under the aegis of Oculoplastic Society of South Asia and the Pakistan Oculoplastic Society. It is really a great cooperative venture that we have started to bring together the oculoplastic community of all the 5, 6, 7 countries that constitute the South Asia, so that we can share our problems, share our difficulties, and find ways to advance the oculoplastics in the region. Oculoplastics is, as you are all aware, a branch which is really very, very wide, and there is a lot of knowledge that we need to have in order to manage the widely varied conditions that we handle. And since our economic conditions are similar, since our problems are similar, we need to work together in order to find the solutions to those problems in our own ways. And there could be nothing better than this initiative, which was taken by our Nepali colleagues, our Bangladesh colleagues, our Pakistan colleagues, to bring us all together. And we had one wonderful meeting that was hosted by Nepal Oculoplastic Society, and the second meeting is being hosted by the Pakistan Oculoplastic Association. I've had the privilege of visiting Pakistan for 3 meetings of the Pakistan Ophthalmic Association, and I was one of those who were involved in the creation or the foundation of the Pakistan Oculoplastic Association. So I deem it a huge privilege with and have a lot of friends from oculoplastics in Pakistan. And it's wonderful that Pakistan has undertaken to host this meeting, and all the effort that has been done by by Dr. Afghani and his team and the Al Shifa Trust Hospital and the Pakistan Oculoplastic Association. We look forward to a great future for working together, solving our problems together. We can extend these activities in the scientific field, in the field of training, in the field of fellowships as the time progresses. At present, we are working to formalize the association by the process of registration, and our Bangladesh colleagues have made a huge effort towards that. I will hand over to Dr. Ghulam Haider to talk more about the organization and about our work that has gone on for creating the infrastructure to have a good association. Dr. Ghulam Haider, the secretary of the association.
Dr. Ghulam Haider, do you want me to introduce yourself?
Okay.
Okay, let me introduce. Yes, just Dr. Ghulam Haider is a very well-known figure, and he is head of the Department of Orbital Oculoplasty and Oncology Services at Bangladesh Eye Hospital and Institute, Dhaka. He is General Secretary of Oculoplastic Society of South Asia. He is General Secretary of Bangladesh Oculoplastic Surgeon Society, and he is awardee of APAO Achievement. So he has a lot of publications, a lot of book chapters that we have not mentioned here. But welcome, Dr. Ghulam Haider. You can now please proceed.
Yes, sir.
Yes, Dr. Ghulam Haider, please.
Full screen.
Yes.
Good evening, everybody. Assalamu alaikum. I'm to talk about our society. It was South Asia. We were in 2021, the 3rd January, Pakistan now, last year, is in Nepal. This is our first meeting of OFSA at current practice of oculoplasty, orbital electron system in this area. And this is the second meeting in Assam, Guwahati. Guruvasa is there. All executive committee body is there. Then again, 3rd annual conference OPI. Previously, the name was Sharp Oculoplasty. Now it is OFSA. Give it a smile. Previously it was Sharp, but now it is OFSA. South Asian session. Let's be photographed. Now, member of OFSA is that in India 13. Now, it's a bit improved. From Bangladesh 12. 12. From Pakistan 10. Previously it was only 1. Now it is 10. From Nepal 4. From Afghanistan 1 and Sri Lanka 1. Our academic calendar whole over the year. Host country now is going on Pakistan. Next host country is India, 4th April, just next one. Then host country in Bangladesh, 4th July. Then whole program will be November. This will be November. Member of our officer is very active, but number is still less. We have to increase above 100. So we should have to increase. Our registration process is going on. All the file in the table of ministry now. I think within 2 months we can get the paper by the grace of Almighty. Thank you, all of you. Thank you. Next topic.
Okay. Dr. Nausheen. Unmute yourself, yeah.
Shall I proceed,
Yeah,
sir?
please. Yeah, please.
Assalamu alaikum, ladies and gentlemen. Good morning, good evening, according to the time zones. My name is Dr. Nausheen Hayat, and I would be the moderator today of this webinar. Just a minute.
You have to start with the video, yes.
Yeah. So first, I would like to, I'm working as a faculty member at the largest tertiary care center of Karachi, that is JPMC, as a orbit oculoplastic consultant over there. So a little bit introduction about the program today. In this program, we would be, we would learn how to, a comprehensive approach towards the management of orbital tumors or ocular tumors in children. This is a very important age group in which diagnosis is a very important. If there is a mismanagement and misdiagnosis, that can lead to disasters in such innocent lives. So we would be sharing, first of all, we would be sharing a little video, and which can give you the glimpse for the inside Pakistan. Although Pakistan is way beyond beautiful than this, but we just try to cover up the best shots and to bring the best shots for you. Dr. Saad, kindly start the video, please.
Dr. Saad, we can't hear the video sound. We can't hear the video. Start from the beginning, please.
Sir, can you hear it?
Yeah, now we can hear. Just start from the beginning, please.
Okay, sir.
Thank you so much, Dr. Saad. Dr. Saad is my co-host today. So I would be introducing, as all the speakers are already introduced by Dr. Afghani, so I would be introducing the conversationalist today, or the panelist, Professor Moin. He's from Pakistan with us. He's the chief editor of the Pakistan's first ophthalmic journal, Dr. Rohit Seju and Dr. Santesh Honavar from India. So now I would proceed towards my first speaker of today's webinar, who is Dr. Maheen Akbar. Dr. Maheen Akbar is an assistant professor of ocular oncology at Al Shifa Trust Eye Hospital, and she's a fellowship trainee over there in Pakistan Institute of Ophthalmology, and she would be talking with us. Dr. Maheen, can you please start? Thank you. She would be discussing the optic nerve tumors.
Can everybody view?
Infant.
Yes, we can. Go ahead, please.
Okay, so Assalamu alaikum. I'm Dr. Maheen Akbar. I'm assistant professor Al Shifa Trust Eye Hospital. Today, I would be presenting a very unique case to you all. A 1-year-old female came to our OPD with the accompanied by the father, and basically with the complaints of left axial proptosis since birth. According to the father, the proptosis had been progressively increasing, and he reported no pain. Initial examination of the child was that the child was healthy. There was normal visual behavior. There was no afferent pupillary defect. Proptosis measured to be about 5 millimeters. Fundal examination of both the eyes were normal. Optic disc margins were healthy. The systemic examination was unremarkable. An MRI was ordered, and this is what we see. Okay.
Yeah.
So the first image, you can see it is a T1 weighted MRI image, and there is a hypo-intense lesion which is present intraconally, and optic disc shadow cannot be appreciated. Similarly, in the T2 weighted MRI image, there is the same lesion goes hyper-intense. It is retroorbital. The optic nerve shadow cannot be seen. Probably the tumor is either involving the optic nerve or is surrounding it in some way. These, of course, were the sagittal views. Now coming on to the axial MRI images, the same lesion can be appreciated. It is present behind the eyeball, intraconally, and the optic nerve cannot be appreciated. So a plan for an interior lateral transconjunctival orbitotomy was made. So in the second image, you can see the tumor, what actually happened when the mass was exposed. A very light to dark violet colored viscous fluid came out. And this is what was taken out from the orbit. And the tumor was in the optic nerve, and probably it was attached to the optic nerve sheath or inside the superficial part of the optic nerve. So the specimen was sent for histopathology. The review came out to be soft tissue sarcoma. Immunohistochemical analysis was done on the tumor cells. The Vimentin came out to be positive. Ki-67 was 70%. EMA was focal weakly positive. And the most important thing was that the BCOR stain was found to be positive on immunohistochemistry. So quickly going through the slide of the histopathology, you can appreciate here that the tumor cells, they're in strands and cords. And we have these hyperchromatic nuclei in them. And the background is that of a myxoid stroma. And hence we came to our diagnosis. Further confirming that was this BCOR stain. In this, you can easily take a brown, you can see that a brownish stain has been taken up by the nucleoli. All these stains, and they form a very diffuse pattern of nuclei taking up the stain. So based on the immunohistochemistry, diagnosis of primitive myxoid mesenchymal tumor of infancy, PMMTI, was made. So the patient's father was counseled, and the patient was properly referred to a pediatric oncologist, but unfortunately become So a patient came with the left eye proptosis again, which was worsening. An MRI was ordered again, and this is what you see. You see that there's a recurrence of the disease here. And now you can even see that the eye had turned into a painful blind eye. Incision in concert with the patient's father was made, and we did a new with us after that. So coming on to the PMMTI and about this case, so this the unique thing about the case is when intraconally in the orbit, which has involved or surround the optic nerve, and no other case to date has been a case of PMMTI in the orbit has ever been reported, and that was done in 2020, July 2020. And that was an extraconal tumor arising in the right lateral orbital wall, sphenoid trigone extending into the lateral orbit. So basically about the tumor, it's a very rare subtype of soft tissue sarcoma with a feature of infiltration of surrounding tissue. The metastasis is found to be very rare in this kind, and it responds poorly to chemotherapy. Surgery is the most effective of the therapies. So far, Elegio et al. In 2006 named this entity, and based on a case series. And after that, there have been approximately 25 odd cases that have been reported, and these are the locations: larynx, pharynx, trunk, head, neck, and limbs that have been reported. So the tumors, they were diagnosed previously as congenital infantile fibrosarcomas or sarcomas not otherwise specified. And because of the advances in immunohistochemistry and cytogenetics, we have been able to come to these diagnoses now. And BCOR gene is strongly expressed in them. In more than 85% of analyzed cases, you find them positive with internal tandem reduplication. So the management options, the best is complete surgical removal, and chemotherapy and radiotherapy, they are also options. And in certain tumors of the body, they have been reported to be helpful in recurrence in all such consequence. Very little encoding for a key constituent BCO or immunohistochemistry can be used diagnostically to separate or differentiate these tumors from other histological mimics. Their own histological mimics, mainly the group of small ovoid round cell sarcomas. Thank you so much. That is all for me.
Okay.
Thank you so much, Dr. Maheen. Any questions from the audience?
Dr. Maheen, can you stop sharing your screen, please?
Dear audience, if you have any kind of question, you can write down in the chat box, and so that we can convey it to all the speakers.
Any comments from the panelists, Professor Ahmed, Dr. Grover, or any Professor Brar?
So we have one question from the audience from Murtaza Junejo. Was the tumor resection done a blind procedure? Why recurrence occurred?
The thing is, much as we could see, it was involving the optic.
I think
yes, basically what you, there is a factor also, we took out the most of the tumor that we could see, but then based on the Chi-67 score, that's also one of the scores that tells you about the recurrence, and the fact that the COVID times came and there was no pediatric oncologist to review and there was nothing done after the surgery. So there are always chances of recurrence in such patients, and because there was no compliance, so probably it recurred because of these two factors.
Okay, thank you, Dr. Maheen. It was a good presentation. Now I would be proceeding to my next speaker, Dr. Fariha Taimur.
Thank you, Dr. Nashi.
Just give me 1 minute, Dr. Fariha. I would like to introduce you. So she's a senior registrar of Orbit Oculoplastics at Al Shifa Eye Trust Hospital. And she's a fellowship trainee in oculoplastics at Pakistan Institute of Ophthalmology. And so, Dr. Fariha, kindly, I hand it over to you. Thank you. I have to stop sharing. Yes.
Good morning to those who are joining us from USA, and good afternoon to the rest. Today, I'm going to present two cases of rare cancer of extraocular muscle in children who presented and were treated in Al Shifa Trust Eye Hospital. Our first case is a 12-year-old girl who presented with non-reducible, non-pulsatile proptosis of left eye with medial turning of the globe. Temporal conjunctiva overlying the lateral rectus muscle was congested. CT scan showed a large mass along the lateral wall of the orbit in which lateral rectus muscle cannot be seen separately. Lateral orbitotomy was performed and a large tumor of lateral rectus muscle was excised. Our second case is a 9-year-old boy who presented with marked inferior dystropia of right eye with a large mass in the superior orbit with dilated tortuous vessels. Imaging showed a large mass along the roof of the orbit causing marked inferior displacement of right globe, and superior rectus muscle cannot be seen separately. Transconjunctival anterior orbitotomy was performed and a large mass was seen to be arising from entire extent of superior rectus muscle, which was excised in toto with gross dimensions of 4 × 2 × 1 centimeter. On the basis of histopathological examination and immunohistochemical staining, a rare diagnosis of alveolar soft part sarcoma was made. Patients were referred for chemo and radiotherapy, and these are the follow-up pictures of the patient. Now, a quick review about this rare entity. Sarcomas, to be more specific, soft tissue sarcomas are the primary mesenchymal tumors that arise outside skeleton, hollow viscera, or parenchymatous organs. The term alveolar comes from its microscopic appearance, as the tumor cells are arranged in the similar pattern as that of the alveoli in the lungs. It's an extremely rare tumor, accounting for less than 1% of the newly diagnosed cancer, more common in females, with average age of onset of 17.8 years and more usually occur on left side. The cell of origin is unknown and still a matter of debates. The most frequent site of occurrence is lower extremities. It has an indolent course and present as a painless mass. The most common presentation for orbital involvement is proptosis. Diagnosis on the first stage needs imaging, but the definitive diagnosis is on the characteristic histomorphological features, which is aided by immunohistochemistry and cytogenetics. On histology, two types of stains are used, hematoxylin and eosin stain, on which pseudoalveolar pattern is seen. This is the histology slide of our patient, showing a characteristic pseudoalveolar arrangement of tumor cells. Then periodic acid shift staining, they are diastase-resistant crystalline structures in cytoplasm of more than 80% of the patient. This is the PS stain section of our patient showing intracytoplasmic white structures. Cytogenetic analysis have revealed numerous numerical as well as structural chromosomal abnormalities. To be very simple, it's an unbalanced chromosomal translocation in which the piece of X chromosome breaks and joins chromosome number 17. Alveolar soft part loci and chromosome number 17 joins transcription factor enhancer 3 gene on X chromosome to form a fusion protein. It is the detection of this TFE3 gene in the fusion protein on immunohistochemistry, which is diagnostic for alveolar soft part sarcoma, and the expression is in the form of nuclear staining. Other markers that are used are Desmin and muscle-specific actin, which are usually positive in these patients, S100, which are seen to be rarely positive, and myogenin and MyoD1, which were initially thought to be very promising markers for diagnosis, but subsequent studies have not revealed convincing expression of either of these. In our patient, nuclear staining of TF3 was positive, which is shown in this slide in brown color. Then this is the Desmin stain section of our patient showing cytomembranous positivity of tumor cells, while the patients were negative for S100 and myogenin. Treatment is complete surgical excision with negative surgical markers, radiotherapy, and chemotherapy. On literature review, we found out that the first ever case of orbital alveolar soft part sarcoma was reported in 1963. Since then, only 64 cases of orbital involvement have been reported, with 7 cases of recurrence and 9 cases of metastasis. Out of these 64, only 12 cases have been reported, which were seen to be arising from extraocular muscles, and 3 which we encountered in our hospital, 2 which are presented here, and 1 which occurred in an adult with lateral rectus involvement who was treated for quite a long period of time as a patient of pseudotumor. Such low occurrence impede the search and make it hard to gather meaningful statistics about the tumor, but these 2 cases strongly advocate the myogenic origin of the tumor. And alveolar soft part sarcoma adds on to our differential of extraocular muscle tumors, apart from rhabdomyosarcoma and extrarenal rhabdoid, which is another rare tumor, not much reported in literature, but we had patients in which the tumor was seen to be arising from extraocular muscles. Thank you.
Thank you.
Thank you so much, Dr. Fariha. It was quite an interesting case. Dr. Afghani, we have another question from the previous presentation. Would you like to
What is the question?
That why the exenteration was not advised in the first place.
I have actually answered the question in the chat box.
Okay.
Yes, because this was not, it's a very mutilating procedure. It was not indicated in this patient. Enucleation was sufficient to remove the tumor.
Okay. So now, any other question from Dr. Fariha?
Can I make one comment about it?
Yeah, please, yes, sure.
Yeah, I have also one case of this, the alveolar soft tissue sarcoma. It's a very interesting tumor. And recently, actually, there is a medication called the sunitinib. Okay. Or it's a kind of a tyrosine kinase inhibitor. It is very well tolerated. It's a pill. And it is interesting, if you put these patients on this pill, it's a long-term treatment. Lasts about a year and a half, actually, if you follow the patient. But you see that over the time, the tumor shrinks, actually. And the first, like you have, comes with a huge tumors, but as it's a kind of a targeted therapy, actually, and it shrinks down and it becomes surgically excisable and decreases the metastatic rate of the patients and increases the survival. I think it's kind of so far shows a good response for this alveolar soft tissue sarcomas actually.
What is these? What are the spellings? Spellings of what?
Yeah, please. If this is what I was about to ask, if you can kindly write it down in the chat box so that we everyone can.
It is Sunitinib, it's a monoclonal antibody, and it stabilizes the lesion. It actually doesn't cause complete cure, but it makes it smaller, avascular, and more amenable for near total surgical excision. So chance of recurrence can be minimal. And of course, you cannot avoid giving radiation because radiation is necessary if you have alveolar soft part sarcoma, but surgery becomes much easier if you were to place this patient on sunitinib. In fact, it is systemically used by oncologists, and these are available in Asian countries. So I think it's easy to procure as well.
Okay, thank you, Dr.
Dr. Santosh. What is the cost of the therapy at this moment?
Sir, it costs about 20 to 30,000 rupees per month in Indian rupees.
Okay. For how long?
It has to be used until the patient shows stable regression, in the sense that if a 40 millimeter tumor comes to about 20 and stays the same for 6 weeks, that means that it has achieved stability. It is no longer regressing any further. Then you opt to do surgery. But if you have a patient where it is inoperable or it is massively recurrent, then you have an option of continuing this indefinitely so that you can avoid mutilating surgeries such as exenteration. So either for stabilization of the disease or preoperative decrease in the size of the tumor so that you can excise, both are indications for use of monoclonal antibodies.
Thank you, Dr. Santosh and Dr.
Khan. So I think I should proceed to our next speaker. I hope we don't have any other question. So our next speaker is quite well renowned, Dr. Hakan Demirci.
We welcome our guest speaker.
Yeah. So Dr. Hakan Demirci is from USA. He's currently serving as a Richard N. Marian Whitham Professor at Kellogg Eye Center, Michigan, USA. He's the Director of Ocular Oncology at Kellogg Center. He's a Fellow in Ocular Oncology at Wills Eye Hospital under Jerry and Carol Shields. He has received a Senior Achievement Award from American Academy of Ophthalmology. Till date, he has 170 publications and 10 book chapters on his credit. So welcome, Dr. Demirci. We are quite, we feel honored to have you on this forum.
Thank you very much. So I can share my screen, I guess, right now.
Yeah, sure.
Perfect. Great. Oh, let's go back. Okay. First, thank you very much for the invitation and the opportunity to join you. It is, I really enjoy all this talk so far, and I think it will be a really nice day, a nice couple of hours, basically. In my talk, I just want to share with you some of my experiences and some of my approaches to pediatric ocular cancers and then ocular tumors. Of course, like in the pediatric ocular cancers, all of the things that we do is very collaborative approach, but I picked 3 topics that I mostly use, and then some of them you can find interesting. So the first one I would like to start is the neurofibromatosis type 1, which is characterized by the benign tumors of the nerves, cafeolar spots, pricklings, and bone marrow, bone deformities and lesions. It has autosomal dominant inheritance with a loss of function mutation in the NF1 gene. What the NF1 gene actually produces is a protein called neurofibromin. This is a tumor suppressor protein, and if you look at down, you will see that this tumor suppressor protein actually down-regulates the RAS pathway or MAC pathway, which I will come a little bit later about why this is important actually. So we know how the neurofibromatosis, the the molecular biology of the neurofibromatosis and genetics of the neurofibromatosis. The most common tumor in neurofibromatosis is plexiform neurofibroma, seen almost in half of the patients. Causes pain, function impairment, disfigurement, can lead to some malignancies. Like so far, what we do as an oncologists or oculoplastic people is like mostly debulk the tumor as much as possible and then do some reconstructions. Like in the upper eyelid, in the patients in the first panel, I debulked the tumor first on the upper and then later on the lower and tightened the lower eyelids, improved her quality. At least she doesn't have that exposure keratopathy or some corneal problems. In the child at the bottom, in the second child, you can see that as the child grew, this child underwent multiple reconstructions, multiple excisions. Still, the tumor keeps coming, keeps recurring, and which is not it's a very challenging case for everyone. But recently, as we much more understand about the biology of the neurofibromatosis, and then all this targeted therapies starts to come into the picture. Now we have several MEK inhibitors that can target actually the biology. One of them is that the medication called selumetinib, which is a MEK inhibitor. I just told you that the NF1, the problem is in the RAS pathway actually. It goes into the RAS pathway goes into the one in the MEK pathway, and then the other is the PI3K pathway. The selumetinib inhibits the MEK, basically. And this is recently approved by the FDA for plexiform neurofibroma, based on two studies actually. The one is about like 20, 25 patients in one study, and then the other one is around like 50 patients. If you look at that, in this study, they showed that there is about 70% partial response, and then the response was durable more than 1 year in almost half of the patients. And the median decrease in the tumor volume is around like 28%. The mean decrease was around like 25%. But interestingly, if you look at the progression-free survival, like 84% of the patients remain disease-free for 3 years in this group who received the selumetinib. And almost half of the patients shows an improvement in the pain or quality of life. Which is very good for this group of patients, actually. In that study, they used the different parts of the body, the plexiform neurofibromas in different parts of the body with good response. But if you look at the ocular side of ocular involvement and the effect on the ocular involvement, don't know so much actually. It's very, very new. But what we know is it is well tolerated. It causes rash, some nausea, vomiting, nothing that bad actually. But the most importantly, causes the left ventricular ejection fraction reduction. So when the patients are on this medication, they need the echocardiography regularly to be sure that cardiac-wise they are doing well. And then they need their kidney functions to be checked to be sure that there is no side effect developed. So I want to share about my experience with 2 patients right now. This was a lady, as you can see, with the plexiform neurofibromas on both eyelids, and it is very extensive actually. So the surgery was definitely an alternative. So we put this patient on the selumetinib therapy. Then you can see that this is almost 5 to 6 months after. Look at the side view. Maybe you can see after 5 to 6 months some improvement in the ectropion actually. Maybe the tumor shrink down a little bit. Her eyes doesn't look that much exposure keratopathy. Not an impressive improvement though. Not the one that you really want to see that it will just go away. This is another patient this was another kid who had multiple excisions and reconstructions and keep recurring. We put her on in a different trial with a different MEK inhibitor, which is called the mirdametinib. And this is about like 4 or 5 months later right now. It stays about the same. It is not progressing, but it doesn't show the dramatic response. But I think these are the good starts for such a challenging cases, and then for challenging cases, and then the cases are very difficult to manage. It seems that selumetinib shows some promising results for plexiform neurofibroma, especially in children, where these tumors grow much faster and much recur. And we know that as the child grow up, the recurrence and the growth starts to decrease in these patients. The treatment is well tolerated, well tolerated, but the patients really need they need echography to be sure that their ejection fractions remain stable. And then there are some new MEK inhibitors are coming into trials. I think as we see these things evolve, we will start to see that some combined therapies with MEK inhibitors and surgical approaches will be kind of the future. Either we are going to excise, put the patients on these medications to prevent the recurrences, or we are going to give the patient medication, decrease the size of the tumor, and then do the surgical excision, basically. This seems to maybe the future for the neurofibromatosis right now. And after the neurofibromatosis, I want to just go towards one of the other topics that I'm going to briefly touch, because I know that Dr. Santosh Anawar, my great friend, is going to talk about more detailedly and then from the Nepal experience. But I just want to show a couple things about this one. This is recently there was an article that was a great job that shows a whole picture of the retinoblastoma presentation in the world, actually. And I look at, this is just recently published from the JAMA Oncology, and they look at all of the lots of countries in the world. And then I look at the Pakistan experience and I compare it with the United States experience. If you look at the Pakistan, most of the patients most of the patients are managed actually either with enucleation or some other disease, the systemic therapy as with metastatic, and only the 14% of the patients are treated conservatively, compared to the United States. Almost 60% of the patients are treated conservatively, that they can save the eye. And then if you look at the stage of the disease or the advancement of the disease, you can see the same thing, that most of the patients come with really advanced stage of patients compared to the United States. But one thing is interesting. Whatever the income level of the countries, the most common presentation is leukocoria, actually. So if we can find a way of detecting the leukocoria really early, or to the parents or to the screeners, then maybe we can make an impact in this disease all over the world. So this is the one thing that we are developing here right now, that what we call the iScreen app, which is a technology that using the cell phone application and then the machine learning to identify the leukocoria. And you can see that it is stages, basically. It's just, you can find it on the Google App Store called the iScreen. It asks some basic questions to the patients. It tried to make it as self-instructive as possible for the people, how to use it. And it looks at asks you to arrange the magnification or distance. And then so far we use it in Ethiopia, actually, in about 1,000 patients. About almost 92% of the time we will be able to detect the pupil. 95% of the time detect the abnormal pupil. And then in eyelid, detecting the eye problems, it's a little bit, that's kind of a little bit high, but around like 85% sensitivity that it can detect eye problem that we are thinking right now. But as the numbers increases, I'm sure that you will, in the machine learning especially, the numbers makes a big difference. As the numbers increase, these figures is going to change. And this cell phone application is, we know that the leukocoria can be easily detected in multiple directions. If you look up, down, right, and left. And in this cell phone application, we use the up gaze, right and left gaze, as well as the primary gaze for the analysis to increase the detection of the leukocoria. And if you guys, it is available. If you guys want to try, play, you can find it on the Google Store. And what I found is that in retinoblastoma management, especially, the team approach is very, very important for us right now. Especially right now, we are using the intraarterial chemotherapy almost in every cases. And then the people who involved in the treatment, the physicians involved in the treatment, like the pediatric hemong, neurointerventional radiologists, counselors, pathologists, they really can put a good input in the management of this patient. So right now we are doing monthly tumor boards. We started with BlueJeans. Now we are trying to evolve into the Zoom program. It's a webinars, every second Tuesday of the month, 1 hour. If you guys want to join, if you guys want to present the case, you are welcome. Just send me an email. It is just a link basically. Because it is, I find that this is very important. The reasoning is that the neurointerventional radiologists, they want to do the intraarterial, but they want to know the results. They want to know how their approach is affecting tumor control, and that gives them a really good input about that. And without giving so much into the intraarterial, I think it changes our management a lot. And thanks to first to Japan and then later to Dr. Abrams and Dr. Gobin, we learned a lot from them. And as you can see in this video, like you can go from the ophthalmic artery and then you can give the chemotherapy to the globe. And you can see that the flash, which is very important. And as now what we learn is that the only access to the globe is not ophthalmic artery actually. You can go from the medial meningeal arteries or ethmoidal arteries and then find the flash. So that's why the interaction with neurointerventional radiologists is extremely, extremely important. And also the pediatric oncologist is very, very important. These are some examples that the patients that in old days we used to enucleate. Now I think we can save them. Really, we can say, for example, this was a 1-year-old patient who has a tumor in both eyes. One eye was very extensive tumor. And after 6 cycles of chemo with intravitreal, this really changed the outcome. This was a case actually from Pakistan that the parents live in the United States. And then the left eye was enucleated. The right eye had a very extensive vitreous seeding. And after 6 cycles of intraarterial and intravitreal chemotherapy, patient responded very well. And it's almost like 2 to 3 years after the treatment. They are doing extremely well actually right now. We are using right now the intraarterial and these treatments in almost in all categories, in all stages of the retinoblastoma. But I find the most effect compared to the systemic chemotherapies, group D and group E eyes. And you can see that there is a learning curve for us. We pass through that stage to some learning curve. You develop some ophthalmic artery occlusions and lots of other problems, but it will get your intervention neuroradiologists learn about this. And I think that's very helpful. And then as the system, as it learns, then you pass through the different, then the complication rates significantly decreases. So without so much detail, the intraarterial chemotherapy with intravitreal chemotherapy significantly improved the outcome of the advanced cases, especially for me, especially the group D and group E eyes. But it needs a strong collaboration between the ophthalmologist, neurointerventional radiologist, and there is a learning curve for neurointerventional radiologists, and maybe the ophthalmologist also when to do any other adjuvant therapy or not. And I'm sure that Dr. Santosh is going to go over all those things much more detailed than me. The other things that I really like collaborate in approaches is the vascular malformations. I found that it is almost like the 25% of all all orbital tumors in the children. It can be, we know that the International Society of Vascular Abnormalities, they classify them in two groups. They can be neoplasms or malformations. The neoplasm groups come into the capillary hemangiomas, congenital hemangiomas, hemangioperitocytomas, hemangioblastomas, but the malformation group comes in the high flow, mixed flow, or low flow groups. And then the high flow group is the IV malformations. The mixed flows are fistulas, and then low flows comes into the venous malformations and lymphatic malformations. We all know about this capillary hemangioma, which is the most common orbital tumor in children that appears shortly after the birth. And I think all over the world, we are using with the propranolol beta blocker therapy with very, very good response actually, but under the close follow-up of our pediatric cardiology colleagues. You can see this patient that after 15 months, who has a very extensive capillary hemangioma, which responded which responded significantly actually in about almost close to 1.5 year therapy. And then after 3 years, there was no follow-up for this case. There was no recurrence for this case. But on the other hand, this case didn't have any significant amblyopia or any strabismus. So after 4 years follow-up, this responded really, actually it resolved by itself actually. The other thing that on the malformation group actually, we classify the vascular malformations in 3 categories: no flow, venous flow, and arterial flow. And especially you can see that the low flow group, differentiate the low flow group than the venous group, which is the varices, is based on that the expansion in the coronal or increased venous pressures. And the lymphangioma, especially in this group, is one of the most commonly seen in children with cosmetic disfigurement and proptosis. And I will say what we do in these days, in old days, I used to do much more excisions, but right now we are going much more into the sclerosant therapy a lot. For example, this kid who came up with a very extensive orbital lymphangioma with recurrences, underwent the sclerosant therapy with the doxycycline and bleomycin. And you can see that it regressed significantly actually. And then she's doing really well, almost like 2 years right now, follow-up wise. We didn't see the recurrence, but it is going to recur probably. There is still something over there, but this was a big improvement for this case. This is another case, for example. You can see on the left eye, in the left lower eyelid, you can see that another lymphangioma, and it extends to posteriorly. For this case, again, we did the same thing. We did the sclerosant therapy for both the malformation posteriorly and then the one anteriorly. Then after that, I excised the one on the anterior one. The posterior one was very residual, actually. It was very small. And then now he joined to the military, actually, for this case. So, and then he can take the excessive exercise, actually. So it seems that in the recent years that this close collaboration with the neurointervention radiologists changed my approach a lot for the vascular tumors, and especially in these challenging cases. I think combined therapies, either just sclerosant therapy or sclerosant therapy followed by surgery, seems that increasing the success in these difficult patients a lot. So with this one, I would like to thank you very much for everyone. And if this is my contact information for anything that I can help, please just don't hesitate to give me contact me at all. Thank you very much.
Dr. Nasheen, your audio is off.
Sorry. Thank you so much, Dr. Hakan Demirci. That was really impressive and quite a massive and huge information for all of us.
Sorry, Dr. Nasheen, let Dr. Demirci stop sharing his screen.
Okay. Oh, yeah, I can see the.
Yeah, okay.
So, Doctor, I would just like to add a little point here about retinoblastoma. I believe my other speakers and fellow colleagues and seniors would agree with me that about the retinoblastoma, I was so impressed by the graphs and all the statistics you showed us today, that in this part of the world, in our region, we need a massive kind of awareness program to be run, particularly in our region for about retinoblastoma, because the center where I'm working, we receive patients from our neighboring countries also, from Afghanistan, from Iran, and I feel so pity and feel so devastated for many of the patients when they reach us, it's already too extremely late for them. And I have seen number of cases in which we treated the patient. Parents didn't listen to us. They were for any reason they were unable to follow up. And later on, after a few years, they come up again with the same child having retinoblastoma occurring in the other eye or with the sibling. So I can recall back in 2012 or 13, when I was a trainee, I tried to write an awareness. I wrote a awareness article and sent it to a leading newspaper, English newspaper of Pakistan. So they didn't find it catchy. So they disapproved my article. We need to, I think my seniors can help, might be helpful in this regard, that we can run some an awareness program.
Dr. Nasheen, we were talking about that. I think there are two questions for Dr. Demirci. One is that the dose of the sclerosing agent, and the second is do neurofibromatosis become aggressive after debulking?
That's a very good question. First of all, the first question regarding the neurofibromatosis, does it become aggressive after more debulking? It is difficult to say. It is difficult because it's a difficult answer and difficult question, but very good question. This is the difficulty, because if you look at these cases that we resect, and multiple resections especially, those are the children's, that they are much more younger patients. If you look at the graph, actually, the progression of neurofibroma graph, you can see that the graph shows that over the years, it really grows and it really changes in that graph. So does it because it is just the natural course of the disease that the disease, because of all these mutations and everything, it is going to progress and it is going to become recurrent, just what it is basically the disease, or because we are doing more excisions that we are feeling that we are causing the disease recurrences. Personally, I am a little bit thinking that rather than we excise and then causes the recurrence, I think this is the natural progress of the disease, because these kids carry this like a mutation in their almost in everywhere in their body that can cause the neurofibromas and then the growth basically. So I'm not so sure it's really the excisions causing it, but as long as we find the right target, combination therapies, it will be probably in the future that we can turn off that protein and then cell proliferation, we will face that problem. That's what I'm feeling it. Regarding the sclerosant therapy, what was the question regarding sclerosant therapy?
The dosage.
we use two agents. The one is the bleomycin, and then the other is the doxycycline. And I can just send you the information, the dose of those two agents, basically. We choose that the bleomycin based on the, if it is really a microcystic disease, then we go with the bleomycin. If it is macrocystic disease, if there are the big cysts, then we go with doxycycline. And then there is both. Sometimes we do the combination. We give a little bit doxycycline, and then on top of it, in the area that we gave, we give some the bleomycin in a foam shape, in a form. It's a kind of a plug that the leakage, and also some bleomycin in the area that is like a microcystic disease. Then I will send you the dose.
Okay, thank you.
How often?
Dr. Demirci, do you use steroids as well along with the bleomycin? Because I have been practicing it as well in lymphangiomas.
I see.
So
this is my advice
there's a
to you.
literature of using steroid, mixing the steroid with it.
We don't.
So
we don't
what's your opinion?
Yeah, we don't mix it. But if it is really, these two things I will recommend based on my experience so far. Don't put any tape on the patient if you are going to inject anyone, because if you put a tape, it causes kind of a reaction towards the tape. So when we use the bleomycin, we don't put any tape to the patients. All IVs put in they put it in like a use that the paper, some like the gas and those kind of things to stabilize lots of things actually. Because whenever you put an adhesive material, the area that you put the adhesive material, it becomes kind of a red and swollen. So try to avoid that one, number one. The steroid, we don't combine it together when we inject. After we inject, if it is developed lots of swelling and lots of inflammation, then I give a very short dose of systemic steroid. Just depends on how they respond, but not originally actually.
Okay.
Okay, Dr. Let me just request one thing to Dr. Gholam Haider. Dr. Gholam Haider has been using, I know since long, this bleomycin and
bleomycin because of lymphangioma, generally before doing the surgery, orbital MRI with contrast first. Then during surgery, debulking and giving bleomycin by seeing the different parts of the orbit where the mass is there, just under microscope. I'm giving bleomycin, few of my cases, use apoptosis with chemosis, and I have got good results, few of my cases. During surgery, debulking and giving bleomycin at the time of surgery, I have gotten good results.
Thank you, Dr. Demirci. There is another question from Dr. Sabah Al-Khairi. Do neurofibromas usually have a more aggressive growth after the debulking procedure?
This has been answered, Dr. Noshin. The next question is actually
common complications
regarding the complications of sclerosing agent.
Okay. Sorry.
Yeah.
And a related question, Dr. Demirci. Do you use imaging control very often with your orbital lymphatic and lymphovenous malformations?
Yes. First, we do these injections under the fluoroscope. So we go and then we go under the ultrasonographic guidance actually. So with the ultrasonographic guidance, we place the needle. And then after that, we give a very tiny amount of the contrast agent to see what is the communication regarding that if the contrast agent will disperse and then go to somewhere else that you really don't want to go basically. And if the contrast agent stays where you want to stay, then at that point, from the same needle without changing it, we gave the bleomycin or doxycycline. This is the approach that we are using. Regarding the complications of the sclerosing agent, so far, I know that the one case, this was a case that the intraosseous cavernous hemangioma. that the people who deal with the intraosseous cavernous hemangioma, they know that they bleed a lot during the surgery. Actually, they significantly bleed, and then and it is difficult to it's almost close to impossible to like resect completely, different from the orbital cavernous hemangiomas. So in one intraosseous cavernous hemangioma, we couldn't access to the tumor towards the ultrasonographic approach. So we tried to go into the ophthalmic artery and then to the lacrimal artery and then to the intraosseous cavernous hemangioma. In that case, we had some, when we give the sclerosing agent, it reflects to the globe, and then there was we can see a small emboli in the in one of the branches of the artery. Actually, that was the only thing that I experienced so far. In the other ones, especially the low flow ones, like the lymphangiomas, we didn't see any complications, except that the eye becomes really swelled up, very like chemotic and like inflammatory, which goes away in like about 2-3 weeks later. Everything quiets down actually as the time passes. And in those cases, some steroid, maybe little help, like a touch of steroid helps to make the things a little bit go faster. But that was the only complication in one cases that we saw. So we are trying to not to go so much through ophthalmic artery and those kind of things since that time. And that's our approach so far in this sclerosing therapy around the eye.
Thank you very much, Dr. Rashid. I think we should proceed with the next one.
Yes. I would like to proceed with our next speaker now. He is Dr. Ben Limbu from Nepal. So Dr. Ben Limbu is a consultant at Tiliganga Institute of Ophthalmology. He is the General Secretary of Nepal Society of Oculoplastic Surgeons and Society. He is the Scientific Secretary of OPSA, Editor-in-Chief in Asia Pacific Society of Oculoplastic and Reconstructive Surgery. CEO of the Global Eye Center, Executive and Founding Director of the Working Vision at USA. Welcome, Dr. Ben Limbu. It's an honor to have you with us. Hello.
Thank you very much. Thank you very much. Am I audible?
Yeah. Please go ahead.
You can proceed, please.
Yeah. Thank you very much, Pakistan Oculoplastic Society, for giving me this opportunity to present our society work that we have done in 2019. And this is about the National Survey on Retinoblastoma among Nepalese children in year 2019. The initiative was taken by Nepalese Society for Oculoplastic Surgeons. So I work in Tiliganga, and currently now I'm the president of Nepalese Society for Oculoplastic Surgeons very recently. So without further delay, the retinoblastoma remains the same as we have seen in 1998. The situation is not well educated among the mothers, and then we have a lot of problems. The child is smiling, but the problem inside the eye is a lot than the child face. So, and then mother cannot appreciate that on time in our part. Moreover, we also have advanced cases of retinoblastoma coming to our center and also all over the other hospital in Nepal. So till now we have more paper published, and then we have revealed that our patients have delayed presentation with retinoblastoma, and there is increased healthcare cost due to referral, and then most of the time the treatment is not available at the rural side of the country. Similarly, enucleation remains the mainstay of treatment. And then death rate has been more than definitely in other part of the developed countries and also in developing countries in compare. So this was the data that we already have revealed in past. The unanswered question in Nepal was, how many patients each year do we have in Nepal with retinoblastoma? And then we don't have any idea about what was the presentation according to the international classification for retinoblastoma, and then also stagings have never been discussed in any of the papers. And reason for increased lag time has not been addressed, and the referral patterns and the reason for referral was not at all mentioned in the literatures from Nepal. And we have not really estimated, we always say that we cannot afford, or our patient cannot afford the treatment, but we have not estimated actually the affordability of retinoblastoma treatment here in Nepal. So with these questions in mind, I came up with a proposal to our society when I became the General Secretary in 2018. I proposed we need to do some kind of multicentric retinoblastoma study so that we know exactly what we are talking about. And then we had a several round of meeting, and then finally I applied for the research grant, and then thanks Cox for giving me this gracious research grant of 10,000 USD. Then we started research with the objective of to see the hospital-based prevalence of retinoblastoma in Nepalese children in 2019, and to report common presenting features of retinoblastoma, to calculate the lag time, and also to describe the reason for increased lag time. And then also we aim for ICRB and staging of all the patients, and also reason for referrals. And then finally, we also thought of calculating the ability to pay for the retinoblastoma treatment. We included all the patients who were newly diagnosed as retinoblastoma with Nepalese nationality in year 2019. And then old patient was also included in the study who were under treatment from previous year. And then exclusion was, we didn't take any international patients in our study. And then also patients not willing to participate in the study was excluded from the study. It was a multicentric, prospective, and cross-sectional hospital-based study in 28 eye hospitals across 7 provinces of Nepal, with priority where the oculoplastic surgeons are working in that hospital. And the study period was 1st of January 2019 to 31st December 2019. And then we define new case as newly diagnosed retinoblastoma or diagnosed elsewhere, but no treatment or intervention made. On-treatment patients or old patients was defined as retinoblastoma case who already under some form of treatment or who have not completed retinoblastoma treatment. And then prevalence of the retinoblastoma hospital-based prevalence was calculated by new patient plus old patient and denominator of total number of children of same age in the hospital. So delayed presentation was defined by lag time more than 1 month. Affordability of treatment was calculated using a catastrophic approach. In this, firstly, we calculated non-food expenses by total income minus food expenses. Individual cost is calculated, individual treatment cost is calculated as per child need. Secondly, if retinoblastoma cost is more than 40% of non-food expenses, then that is considered as unaffordable treatment. So we had a special questionnaire, semi-structured questionnaire for this study purpose. And also we have a Google form that was designed to be filled by respective hospitals. So actually they first do record in the paper, and then they transfer it into the Google form. And then we also, as a supplementary form, which explain about different ICRB classification and also staging of the retinoblastoma. And this was supplied with all the forms so that it is easy for the people to fill up the forms. We also develop a minor consent form where we have clearly mentioned what is all about the study and also about the expected risks of including into the study. And then a patient always has the right to quit the study. And then finally, we got approval from government of Nepal, Nepal Health Research Council permission to conduct this study throughout the country. So 28 Eye Hospital took the initiative to achieve the goal of this study. So we packed the questionnaires, we delivered them, and then we also provided a one-day training under the leadership of our immediate past president, Dr. Basantara Sharma. We trained our all the respective collaborating hospital doctors about how to fill up the forms, how to examine the child with retinoblastoma, and also how to fill up the Google form online after filling up in the paper sheet. So results, out of 28 collaborating eye hospital, only 10 eye hospital were eligible for the retinoblastoma. That means only 10 eye hospital got the cases of retinoblastoma. We actually got 102 patients of retinoblastoma during the study period in 2019, but 31 were international patients, so we excluded them, and then 71 patients included in the study. Out of that, new and old patients were only 34. New were 13 cases of new retinoblastoma were detected in 2019. And then the rest 21 were on-treatment patients or old patients with retinoblastoma. We have a little bit more females in our study, and then family members were more than 4 in our study. And then the annual income was better actually in our patient's family than the national average annual income. And then most of them didn't have any insurance facility. Leukocoria still remains the main complaint. And then prevalence of the retinoblastoma in our study was 2.6 per 10,000 children visiting to eye hospital, aged 0 to 6 years during 2019. And new cases were 13. Live birth during the same year in Nepal was 5,95,724. So RB occurrence in Nepal was estimated to be 1 in 45,000 live birth during that year. So lag time was 6 months, and then majority of the patients came late. That means more than 1 month, 76%. The reason for coming late was, majority was because they were not aware that leukocoria was a sign of, maybe a sign of bad disease like retinoblastoma. And then they doesn't know where to go after seeing that white reflex, the second cause. And then lack of money was the third cause for delayed presentation. Most of the patients presented at group D or group E, which means they presented very lately, though they presented with leukocoria. And then most of the patients who have group A, B, C were patients who were bilateral, who had bilateral retinoblastoma, and then it was an accidental finding on examination under anesthesia. So majority were group D and E. Similarly, staging, we had a good number of patients in group stage 0. And then requirement for referral from different hospitals that we observed was 23, which is 67% patient have to be referred to either Kathmandu or abroad. And then we saw what was the reason, why they are referring the patient, why we are increasing the cost for referral. So we saw that 82% that there is no systemic chemotherapy in that locality, for which patient have to travel to different city or to Kathmandu. So similarly, we observed that the plan, this was a plan on the same time. We observed that still the enucleation remains the main plan for the retinoblastoma management. So what we observe here, affordability, we calculated the non-food expenses of the patient family, and then we observed that 100% of parents' income was unaffordable for retinoblastoma treatment cost as compared to their non-food expenses, which is actually very alarming that all of the patient family cannot actually afford to the treatment cost. And then a last slide, I want to summarize. So this was a hospital-based prevalence initiative taken by NESOS. And then we observed that 2.66 cases per 10,000 children aged 0 to 6 years in 2019. 79% of the patients were unilateral, 21 were bilateral. Mean age of diagnosis was 35 months, though it was 43 months in unilateral and 20 months in bilateral. Similarly, 3% of the child had family history of retinoblastoma. 76% of the children presented as ICRB group D and E. As I said, they presented very lately. Early diagnosis was rare in our study because whatever we saw, group A, B, C was coincidental finding. 88% of the children this is good that they were in stage 0. Mean lag time was 6 months. And then as I said, that the majority of the patient doesn't know, they are not aware where to go after seeing leukocoria. And similarly, 46% of the parents brought the child late because they believed that RB was normal. And lack of money was third reason for delayed presentation. And 100% of the parents of RB children was not able to afford retinoblastoma treatment cost as per our study. And then the main reason of referral of the child was systemic chemotherapy. And then the enucleation still remains the main treatment modality in our part. And then systemic chemotherapy was second to enucleation. Thank you very much for your kind attention. So with this, I want to give a small message that awareness to the community alone is not adequate to treat retinoblastoma on time, because by the time leukocoria appears on the child, it will be definitely either group C, D, or E. So to react or to catch the child early, I think we need to develop some kind of national screening eye program, which has to be integrated not just for retinoblastoma, but for other eye diseases as well, so that we can pick up the child in the earliest. Otherwise, creating awareness and saying people white reflex is a sign of retinoblastoma, this will definitely bring more child to the hospital, but it will again bring the child in very late stage. Thank you very much. Thank you.
Thank you so much, Dr. Benlimbu, for your elaborative presentation. Do we have any question from the audience or from the panelist?
I will only say that I'm so glad that Pakistan of Oculoplastic Society took this initiative of taking up oncology in children, and I'm glad that Dr. Benlimbu has taken this initiative, which has pointed out the extent of the problem and the financial difficulties and the infrastructure difficulties that our region faces. So it is very important that we create more awareness, not just in the general public, but also amongst the politicians and the decision makers regarding this, so that we can create more facilities, and the government and the NGOs will have to step in to provide the support for those patients who get this disease. Because as he pointed out, the financial viability of affording by the parents is virtually non-existent. So that is where the role of advocacy will come in, where we have to involve the governments, decision makers, and the non-government organizations, so that these patients can be effectively treated in the region. And we must increase the educational efforts all over the region by working together, so that more and more people are trained and more facilities are created at, if not district level, at least the medical college level. Only then will we be able to provide effective treatment to our populations.
It's a nice idea, Dr. Grover. I would like to welcome, I can see Professor Zahid Kamal also. He has joined us. He's among the senior and leading orbit-ocular plastic surgeons of Pakistan, and he's among the panelists as well. Welcome, Dr. Zahid. Assalamu alaikum. Any comment from the speakers with Dr. Ben Limbu? Yes. So I think we should proceed to next speaker. I would like to introduce our next speaker now. He's Professor Ebrar from Peshawar. He's one of the, again, a very renowned person among the ophthalmic community of Pakistan. He's serving as the professor of ophthalmology and as a consultant orbit-ocular plastics at Khyber Teaching Hospital, Peshawar, which is one of the leading hospitals in Pakistan. He's the president-elect of Pakistan Ocular Plastic Association, and he was the ex-president of OSP, Khyber Pakhtunkhwa chapter, and he had his fellowship in orbit and ocular plastic from Leicester's, UK. Welcome, Dr. Ebrar.
Thank you, Dr. Nusheen.
I would hand over the platform to you. Please kindly take the honors. Thank you.
Can you see my screen?
Yes, we can see you, but we cannot see your screen.
Start sharing your screen, Dr. Ebrar. Yeah, and the bottom or on top, there will be a green logo with share screen. Yes, that's
good. Can you see it now?
Yeah, you can see. Yeah, that's right. Please go ahead.
Okay, thank you very much. Bismillah ar-Rahman ar-Rahim. I'll be talking a little bit about rhabdomyosarcoma, a comprehensive approach. Now, as you know, the rhabdomyosarcoma is the most common soft tissue sarcoma in the children. Although overall it is rare, but most common soft tissue sarcoma in the children. About 4.5% of all cases of childhood cancer constitute this rhabdomyosarcoma. It's a malignant tumor of mesenchymal origin and arises from primitive cells that have the tendency to develop into skeletal muscle. Now, it is distributed throughout the body. The orbit share is about 7%. So 7% of the rhabdomyosarcomas, they involve the orbit. Now, these are the typical cases, 2 typical cases I have selected because most of them, they present like that. The fullness in the upper lid, the rhabdomyosarcoma, which is involving the superior orbit or usually superior medial orbit, they present like that picture in the right, and then the tumor, which is involving the inferior orbit, that is involving the lower lid or fullness in the lower lid. Now, histological classification, this is important because it influences management plans and patient outcome. Now, the embryonal type is about 55%, the most common one. The Botrite variant is the least common. The alveolar one is 20% about, and undifferentiated sarcoma, again 20%. Now, spread. It's a malignant tumor, so there is a local as well as distant spread. It metastasizes to predominantly lungs, bone marrow, bones, lymph nodes, breast, and brain. It's important to know this because when an advanced case of rhabdomyosarcoma comes to you, then you have to think about these metastases and we select the investigations accordingly. The diagnosis, of course, history and examination. History, it's usually in the form of, again, proptosis or swelling in the upper lid or in the lower lid. And here we have to consider because we are seeing so many cases of inflammatory origin, so sometime even a case of, but you will be considering it's a case of orbital cellulitis or inflammatory orbital disease that may come out to be rhabdomyosarcoma. Therefore, you must be having high suspicion for this tumor as well, because it's important to diagnose it at an early stage. Examination, again, the proptosis, and as I showed you in the figure, in the pictures, we'll see more pictures. And CT scan is the mainstay or imaging studies, including CT scan, axial and coronal view, and it is helpful in evaluating for bone erosions as well, if it is present. And moreover, follow-up of the patient response to therapy is detected on CT scan. MRI of the orbit and head, which improves definition of the mass and its invasions to other soft tissue structures. Bone scanning is needed to search the metastasis to the bones. And ultrasonography of the liver is needed if you suspect liver metastasis. So these are the imaging studies which may need in case of diagnosis or its metastasis. Now in imaging, you can see the CT scan. There is a typical tumor. On the left-hand side picture, you can see an area involving the medial orbit, and it is isodense with the muscles. Then on MRI, you can see on the left-hand screen, there is an MRI again showing the tumor which is involving the superior medial orbit. Other investigations, I'll skip this slide because of constraint of time, but you can select accordingly to when you suspect the involvement of other tissues in the form of metastasis. Treatment plan is complicated and prolonged. Ophthalmologists and pediatric oncologists should be in close liaison. Now, following biopsy, staging for the orbital rhabdomyosarcoma is internationally uniformly done. There are 4 groups. When you excise the tumor and you are sure that you have completely resected it, then it comes in a group 1. Group 2, when you excise the tumor and still you suspect that there is a microscopic disease left there, that's the group 2. Group 3 is the one in which you try to remove the tumor, but still gross residual disease is left. And group 4 is the distant metastasis present at onset. Now, treatment, current management includes surgery, irradiation, and chemotherapy, depending on the stage. Now, group 1, chemotherapy only, and that includes vincristine and actinomycin. And you know, this is the group in which you have excised the tumor, as so surgery is done first, where possible. So you remove the tumor in group 1 and you are sure that nothing is left, still you need chemotherapy in the form of 2 drugs, vincristine and actinomycin. Then group 2, where you know that a microscopic residual disease is there, then a combination of chemotherapy in which vincristine and actinomycin is added with cyclophosphamide as well. And at the same time, radiotherapy is needed. About 36 grades amount of this radiotherapy is needed, radiations. Then group 3 disease, where we know that a lot of our residual disease is left, then a combination of, again, this vincristine, actinomycin, and cyclophosphamide, and the radiation dose is increased to 45 gray. Then last one, the group 4, where the patient has got metastasis at presentation. A combination of intensive chemotherapy and radiotherapy is needed, in which sometimes doxorubicin is added to the above mentioned drugs, and extensive radiotherapy, even to the areas where possible, the metastatic areas are also irradiated where possible. And there is some difference of European pediatric soft tissue sarcoma study group, and they use ifosfamide instead of cyclophosphamide. Rest of the regime is almost the same. Surgical care now, which we have discussed already 4 groups, that is for very straightforward cases but in every case it is not possible to start with surgery. So the surgery indications here in this slide we can see. Surgical management of rhabdomyosarcoma varies depending on location of the tumor. If feasible, remove the tumor promptly and without unacceptable disfigurement or loss of function. Naturally, if the disease is located very deep near the optic nerve tumor, or where you if you want to remove the tumor and you can damage the other vital structures, then it may not be possible to start with the surgery. There are other choices. Even if metastatic disease is present, surgical excision of the primary site should be performed if possible. This is the other extreme. Then surgical result helps to determine the clinical grouping, which we have already discussed, to be used for treatment stratification. And for tumors that cannot be excised at diagnosis, a second look procedure may be appropriate after a period of chemotherapy. And this happens to many of our patients, that when they present at a very late stage, where I'll show you some cases. So then we first refer them to oncologists. They give chemotherapy as well as radiotherapy where needed, and then they send them back to us for surgery. Now, this is a straightforward case. The involvement is inferior orbit. We removed the tumor and we were suspecting that we have excised it completely. Now, this is on the right hand side, the photograph is after the surgery. And this is the after chemotherapy. Still, we sent the patient to the oncologist and chemotherapy was given. So this was a straightforward case. But coming to this case, now, this was February 2016 when this case presented to us on the left-hand side, if you look at the picture, and then he disappeared. We took the biopsy, we advised the protocol, but they disappeared. And after 10 months, about not 10, 8, 9 months, they appeared, and you can see the huge tumor which is involving the orbit, and it has eroded through the bones as well as it has involved the eyeball. Now, what did we do? We sent this patient to oncologists. They gave chemotherapy and radiotherapy, and they sent them back to us, and then we performed exentration. Now, this child is after exentration, but unfortunately, he also developed metastasis and he died after 6 months. So mortality is high, it's related to age, site, and histology. The 5-year survival rate is highest in children aged 1 to 4 years and worst in infants and adolescents. Then regarding sites, orbital and genitourinary tract, they are the most favorable sites, about 80% 5-year survival rate. Embryonal histology has good prognosis and followed by alveolar one. Portoid one is the worst, as we discussed before. Now, 3 or 4 slides of some original work. There's a retrospective case series. We were able to collect 12 cases in the last 5 years. And regarding demography, the average age was 7.2 years. Gender, you can see 66% are male, that 2/3 are male and 1/3 are female. And laterality in most of the series, we see that right eye is involved. Now, these are those 12 cases at presentation. Now, here I just want to point out in the upper row, the second one from left is the highest age which we have encountered, and that is about 19 years. And the minimum is the congenital one. In the lower row, you can see the third one or the middle one, the child. This was the congenital rhabdomyosarcoma. So congenital rhabdomyosarcoma is rare, but it does present. So here we can see. Now, after listening to these presentations of Dr. Mahin and Dr. Faria, I will dig out the biopsy report. What were the tumor markers used? It could be a case of alveolar type of soft part sarcoma. I'll see. So these are the 12 cases. And the presentation was upper lid mass in 7 or 58%, lower lid mass in 25%, proptosis alone without any mass, the deep tumor, 8.3%, and proptosis involving the swelling of both upper and lower lids in 8.3%. As far as histological type is concerned, embryonic type was 66%, alveolar was 25%, and 8.3% were undifferentiated. Now this is the outcome. 5 are doing well. After about 2 of them have completed 5 years, and the rest of the 3 are about 3 to 4 years. So for the last 3 to 5 years, only 5 are doing well. 4 developed recurrence, and 3 of these 7 developed recurrence, and 3 of them have died since then. So 25% death rate. In the picture, you can see the lowest picture. This is the worst tumor I have ever seen in my life. And you can see the huge tumor involving the right orbit. And she presented earlier, not that earlier, but again she disappeared. And then she presented in a condition like that, and she expired within 15 days after the presentation. Thank you very much.
Thank you so much, Dr. Ebrar, for the valuable information and beautiful presentation. I believe we don't have any questions right now. So as we are getting short of time, I would like to invite my other speaker, Dr. Mehboob Qadir.
Dr. Ebrar, please stop sharing your screen. Yeah, thank you. Yeah. Dr. Mehboob.
Assalamu alaikum.
Dr. Mehboob. Okay. So we have Dr. Syed Mehboob Qadir from Bangladesh. He's a consultant at Sheikh Fazilatun Nisa Mujib Eye Hospital Training Center, Bangladesh Eye Hospital, and treasurer of OPSA, and he's the member of International Society of Ocular Oncology. Dr. Mehboob, I welcome you on this forum. Kindly start with your presentation. Thank you.
Thank you. Happy New Year to all of you.
Yeah, Happy New Year to you. And
just
sorry, in hurry of all this, we forgot.
Now I am going to present on management strategies for orbital malignancies in children. Orbital malignancies may be primary, secondary, or metastatic. The most common primary orbital malignancy is rhabdomyosarcoma. Orbital invasion of retinoblastoma is encountered as most common secondary orbital malignancy. Neuroblastoma, Ewing sarcoma, and acute lymphoblastic leukemia are the distant tumor to spread to the orbit. The diagnosis of orbital malignancy depends on clinical evaluation and assessment of imaging study, various techniques of representative tissue sampling, modern histopathological examination, immunohistochemical analysis, cytogenetic study, and finally, the management strategy include efficient TNM study. Most of the patients are treated by multimodality approach, by multidisciplinary approach. And the management strategy differ from patient to patient and center to center based on available facilities. We already informed that rhabdomyosarcoma is most common primary orbital malignant tumor and most common in the children. It may occur in any age between the 1 to 20 years of age, but the mean age is 8 years. The hallmark of the presentation is the sudden onset and rapid progression of unilateral proptosis. Painful may be present in 10% cases. The most common site is superior or superior-nasal orbit. It's usually embryonal rhabdomyosarcoma affected in superior-nasal orbit, and alveolar type affected in inferior orbit. Diagnostic workup includes detailed history and clinical evaluation. I always prefer CT scan of the orbit, and the confirmatory diagnosis is biopsy followed by histopathology and immunohistochemical analysis. We already known by another speaker about the tumor marker like desmin, vimentin, and muscle-specific actin for confirmation of the rhabdomyosarcoma. The management strategy of rhabdomyosarcoma differ from time to time. Before the establishment of the intergroup rhabdomyosarcoma group, the exentation was the mainstay of treatment. But the current concept is biopsy followed by chemotherapy and radiotherapy. The goal of the biopsy is the complete excision of the tumor or debulking of the tumor without damaging the normal structures of the orbit. Management strategy of the rhabdomyosarcoma depends on the IRSG post-surgical pathologic grouping. The grouping was first established by the IRSG group, but further modified by Shields et al. We already informed about the post-surgical pathology group by Professor Ibrahim Hussain, and he also mentioned the details about the treatment of the grouping. Just I want to mention the innovative technique is interstitial brachytherapy. Interstitial brachytherapy for orbit using this is safe and effective modality of local treatment for appropriately selected orbital soft tissue tumor. Brachytherapy resulted in excellent disease control with significant reduction of dose to surrounding ocular structures compared to external beam radiation therapy. Prognosis of rhabdomyosarcoma depends on the type of histologic type and post-surgical grouping system, and also age of the patients. The most common rhabdomyosarcoma histologic type is embryonal, and that is 80%, and 5-year survival rate is 94%. Alveolar is less common, and the 5-year survival rate is 65%. Pleomorphic, least common but better prognosis, that is 97%. Orbital rhabdomyosarcoma presenting in infants less than 1 year of age follows a more aggressive tumor with poor survival rates of 56%. Ocular adnexal lymphoma is the disease of adult and elderly, but literature reported the young children and adolescent age group are affected by ocular adnexal lymphoma, and literature also reported that lymphoma has been reported as the most common primary malignant tumor in Asian countries. The age range from 6 years to over 70 years, and the most common ocular adnexal lymphoma is B-cell non-Hodgkin lymphoma, that is 94%. I always prefer CT scan of the orbit to diagnose radiological diagnosis for the disease, but the confirmatory diagnosis is biopsy followed by histopathological and immunohistochemical analysis. The immunohistochemical staining are IRTA1 with TBET is the strong positivity for extramolar marginal zone lymphoma, CD10, BCL2, and BCL6 for strong positivity for follicular lymphoma, and MYC protein BCL2 and BCL6 for strong positivity for diffuse large B-cell lymphoma. The radiotherapy and systemic chemotherapy are the mainstay of treatment for ocular adnexal lymphoma. Radiotherapy is used for localized orbital lymphoma and excellent tumor control rate, and chemotherapy is used in combination with radiotherapy in the cases of systemic lymphoma or secondary lymphoma, or in some cases of high-grade lymphoma. Immunotherapy like interferon alpha and rituximab are using as monotherapy or in combination with radiotherapy or chemotherapy. Rituximab can be used in combination with chemotherapy known as R-CHOP chemotherapy for the treatment of diffuse large B-cell lymphoma, follicular lymphoma, or mantle cell lymphoma. Another malignancy, adrenocystic carcinoma of the lacrimal gland, is the disease of fourth decade, but it has tendency a bimodal occurrence second and fourth decade. And the literature reported the age range 6 to over 70 years of age. I always follow the management plan score for lacrimal gland tumor. The score varies from -8 to +8. If the management plan score is -8 to +2, that is suggestive of malignancy. CT scan of the orbit showed enhanced irregular heterogeneous mass involving the lacrimal gland that is molded to the globe and lateral orbital wall. Bone erosion and calcification may be found on CT scan. The complementary diagnosis is histopathological examination and immunohistochemical analysis. MYB protein is the strong positivity for adenoid cystic carcinoma. Management strategy includes for small lesion, we go for complete excision of the tumor followed by adjuvant radiotherapy and chemotherapy. But the lesion is extensive or large lesion, we go at first initial biopsy for confirmatory diagnosis. After initial biopsy, 3 cycles of neoadjuvant chemotherapy. Literature reported intraarterial chemotherapy is the best result or excellent result, followed by complete excision of the tumor, then adjuvant radiotherapy and chemotherapy. Excision is rarely done nowadays. Orbital invasion of retinoblastoma is the most common secondary orbital malignancy in children. It is found in neglected or untreated case of retinoblastoma in developing countries, and the orbital extension may occur through the optic nerve or the sclera, and the orbital invasion of retinoblastoma is the potential risk factor for distant metastasis and needs multi-modality treatment approach. Includes neoadjuvant chemotherapy for chemoreduction, followed by eyelid sparing excision or enucleation with resection of orbital tumor, then adjuvant chemotherapy and external beam radiation therapy. For prevention for secondary occurrence of orbital retinoblastoma, during enucleation, we should dissect the long optic nerve stump, and when retinoblastoma cells are present at the cut end of an enucleated optic nerve, adjuvant chemotherapy together with orbital radiation therapy reduces the risk of metastasis. The triadental retinoblastoma, the rate of triadental retinoblastoma from 5 to 15% of bilateral retinoblastoma. Before the age of 1 year, the retinoblastoma is treated with radiotherapy. The pineal triadental retinoblastoma can develop, and the treatment includes high-dose chemotherapy with stem cell rescue. Now, metastatic cancer of the orbit. Most common are neuroblastoma, Ewing's sarcoma, and acute lymphoblastic leukemia, and commonest presentation are proptosis, ptosis, restricted motility, and ecchymosis. In children, distant tumor metastasizes to the orbit, then to the globe. For diagnostic purpose, if no primary tumor is known, we go for excisional biopsy or incisional biopsy. If the patient has a known history of cancer, a fine needle aspiration biopsy can be done. Neuroblastoma is the most common metastatic orbital cancer that may be bilateral, and presenting features are bilateral ecchymotic proptosis, motility restriction, and subconjunctival hemorrhage. The primary site are abdomen or mediastinum or neck. The most common primary site is adrenal gland. CT scan showed bone destruction. Metastasis can occur in the late stage of the disease. Biopsy is mandatory for confirmation of the diagnosis, followed by histopathology and immunohistochemical analysis. The tumor marker are neuron-specific enolase and neuron filament. Chemotherapy is the mainstay of treatment. The survival rate is related to the patient's age at diagnosis. Before 1 year of age, better prognosis and 5-year survival rate is 85%. After 1 year of age, 5-year survival rate of 36%. Unfortunately, all the diagnostic cases is over 2 years of age. USA FDA approved the recent targeted therapy, dinutuximab, for the high-risk neuroblastoma, and other targeted therapy are quizotinib with chemotherapeutic agents topotecan and ceritinib with cyclin-dependent kinase 4 and 6 are used as targeted therapy. Ewing's sarcoma is the highly malignant tumor and commonly involve the long bones, ribs, and pelvis. Presenting features is non-tender palpable mass, apoptosis and mechanical ptosis, motility disturbance, and CT scan showed variable enhancement of irregular heterogeneous lesion and showed bone motor destruction, bone involvement.
My apologies, sir. We are getting short of time.
Okay.
And we are still left with
tumor marker are CD99 and O13. The mainstay treatment are multi-agent chemotherapy followed by definitive surgery with radiotherapy. Recently, high-dose myeloablation therapy and stem cell transplantation is under investigation. And the last metastatic tumor in our in my presentation is acute lymphoblastic leukemia, most commonly occur in children between the 2 to 5 years of age. We can confirm the diagnosis by CBC, complete blood count, and peripheral blood film. And bone marrow examination also is the confirmatory diagnosis. CT scan may help for the biopsy, incisional biopsy. For ophthalmological role is for incisional biopsy. The chemotherapy is the initial treatment of choice. Chemotherapy for all acute lymphoblastic leukemia consists of 3 phases: remission induction, consolidation chemotherapy, and maintenance therapy. Recent treatment options are tyrosine kinase inhibitor for Philadelphia chromosome positive patients, rituximab for CD20 positive patients, and stem cell transplantation can be used. Now, conclusion. For diagnosis of the orbital malignancy, need high index of suspicion for clinical diagnosis of malignancy and needs multidisciplinary approach. Maximal resection is the preferred option for the biopsy. Immunohistochemical staining is important to confirm the diagnosis. PBF should be done to rule out leukemia. PET CT scan for assessment of distant tumor and effectiveness of the treatment. Advanced therapeutic options have improved the survival rate. Thank you all.
Thank you, Dr. Syed Mehboob, for this beautiful presentation. I would like to invite my next speaker, Professor Mohammad Amir Yaqub. So, he's a consultant and professor Orbit Oculoplastics, and he served as the past president of Pakistan Oculoplastic Association, and currently he is the executive vice president of Ophthalmological Society of Pakistan. Dr. Amir, kindly please start. Thank you.
Thank you very much, Nausheen. It's a pleasure to be speaking to such a large and bright gathering of oculoplastic surgeons. So before I start my presentation, I'll just have a short video about to introduce the CyberKnife and how we're using it for treating some of the tumors in the brain and the rest of the body.
We can't hear the sound.
Okay, it's all right. We can just.
So basically, and this CyberKnife surgery is a specific type of radiotherapy where the radiation beam is very highly focused. And because of the precise imaging and stereotactic plotting of the lesion, the robotic arm of the CyberKnife moves along with the body, with the tumor, because there are movements of the body. So the radiation beam is focused only on the tumor and avoids any damage to the surrounding tissues. So that's why it's such a advanced treatment. It's not curative, but it does provide a lot of reduction in the size of the tumors, and it can help in reduce the in post radiation surgery. The other advance in this is the proton beam therapy, which will also be introduced a little bit in this movie. So this is Mr. John Adler, who is the inventor of the CyberKnife. So it is the robotic arm of the CyberKnife, which moves along with the body movements and the patient.
You know, ask a time.
So now I'll just come to the presentation. Just to introduce this treatment, which is available, has become available in recent years in our region as well. We have one CyberKnife which is working in JPMC Karachi, and there are two being installed, in one in Lahore and one in Islamabad. So basically, there are different techniques which are used to kill tumor cells, which include heating, freezing, radiation, chemotherapy, including the tumor blood supply, injection of caustic agents, or a combination of these. So the CyberKnife uses the radiation treatment. Radiosurgery obviously involves radiation, which is highly focused onto the region of the involved tissue, and this stereotactic surgery focuses the radiation exactly where the tumor is. Initially, it was a fractionated radiotherapy, which was delivered by a linear accelerator, but now the stereotactic surgery, which includes Gamma Knife and CyberKnife, have evolved to apply this radiotherapy in a very highly focused manner. So what is a CyberKnife? It's a lightweight linear accelerator, but it is mounted on a robotic arm which moves along with the patient's body movements. The tumor itself is mapped very accurately by pre-treatment imaging, and then this imaging is fed into the computer, and that controls the movements of the robotic arm. So there have been various models that have been introduced since 2001, and the current latest system is the S7 system, which was introduced this year. In stereotactic radiosurgery, the word stereotactic refers to a three-dimensional coordinate system that enables accurate correlation of the target with the patient's diagnostic imaging, and the radiation beam is then focused directly onto the tumor itself, avoiding any damage to the surrounding tissues. So this may also be called stereotactic body radiation therapy if it is used outside the central nervous system. So basically, radiation kills the DNA of the cancer cells. It is a non-invasive treatment for cancerous and some inflammatory conditions as well, and it is used to treat conditions throughout the body. That's the advantage of the CyberKnife. Gamma knife only treats tumors around the head and neck. So CyberKnife treatments usually are performed in 1 to 5 sessions, and it has helped a lot of patients and has been proved to be quite safe. So surgery then is usually preserved for treatments limited to the optic nerve and causing extreme proptosis, and in patients who have already developed blindness due to these optic nerve tumors. The safe dose of the radiation to the optic nerve has not yet been determined, but it's reported that about 8 GYs of dose to the optic nerve and chiasma are safe. Usually with the surgery, visual improvement does not happen, and any surgery to the optic nerve usually results in blindness. But with radiotherapy, you might be able to preserve vision for some time. Various treatments, conditions that can be treated with this CyberKnife include intracranial and skull-based tumors, and certain extracranial tumors like tumors in the lung, liver, kidney, and prostate. So optic nerve tumors this is a good alternative for treating optic nerve gliomas and optic nerve sheath meningiomas. So in this study, the authors reported that it could become a treatment of choice for optic nerve gliomas. So it can also be used for periocular lymphomas, and optic nerve gliomas, as you know, are most common tumors of the optic nerve, which account for about 66% of all primary optic nerve tumors and about 1% of all intracranial tumors. Mostly they are sporadic, but they have a good, well-established relationship between tumor and the neurofibromatosis type 1. About 10 to 30% are unilateral, and majority involve some combination of involvement of optic chiasma, tracts, or hypothalamus. This was a child who presented with proptosis in the right eye with restricted ocular movements because of the size of the tumor, and the eye was already blind when this patient presented. Nerve sheath meningiomas are tumors which are present in an older age group. Other optic nerve tumors which can present in children include lymphomas, which have already been discussed, and neuroblastomas metastatic to the orbit. As already said, that one of the functional CyberKnives available in Karachi is in Karachi, but there are 2 which are being installed, one in Lahore and one in Islamabad. So in conclusion, CyberKnife has proven to be of great value in management of orbital metastases and other optic nerve tumors. It also seems to be a safe alternative to traditional radiotherapy of orbital tumors. Thank you very much.
Thank you so much, Dr. Amir. It was a very informative presentation about the CyberKnife, and I hope the 2 other facilities would start functioning soon. I would like to invite my, I think we don't have any question right now. So I should proceed to my other speaker, Dr. Santosh Gruver. From India. So Dr. Santosh, sorry, I'm extremely sorry, Dr. Santosh Honover. Sorry, he's the director in ocular oncology and oculoplasty at the center of, sorry, Sighem, Hyderabad. Sorry if I'm calling it out wrong.
Center for Sight, Hyderabad.
Sight, Hyderabad. Okay, sorry. There is some error here. He's the director in National Retinoblastoma Foundation, and he's been awarded with the Shanti Swaroop Bhatnagar Award in Science and Technology. He got a Life Achievement Award from American Academy of Ophthalmology, and he's serving as the editor of Indian Journal of Ophthalmology, which is quite a prestigious journal in our region. I welcome Dr. Santosh. Kindly proceed with your presentation.
Thank you, Navshin. I thank your society for inviting me to speak on retinoblastoma. I'll share my screen. Is it visible?
Yeah.
Yes, now we can see your screen.
All right. I'll be talking about some of the recent advances in the management of retinoblastoma. Retinoblastoma management has undergone a paradigm change. As you see here from this slide, from about 98% mortality in 1900s, we have moved to more than 98% survival. That's a big jump. And that's mainly happened because of these evolutions which I have listed over the timelines. When we talk about retinoblastoma, we talk about life salvage as the primary goal, followed by eye salvage and vision salvage. Let's look at some of the recent advances in vision salvage. Let's go the reverse way. Trends in focal therapy. Of course, cryotherapy is still used very effectively for peripheral retinal tumors, but for some tumors which are located in the center towards the optic nerve or in the macular area, if you were to do photocoagulation, that would produce a very large scar. Suppose this is a tumor. The size of the scar that is produced is much larger than the tumor, and you can see the blood vessel in the region blocked. And that can be avoided by using transpupillary thermotherapy. This is a standard of care for focal tumors which are in visually crucial areas currently. And you see here that the scar is very crisp with TTT. And the size of the scar is not larger than the tumor because you do it right on top of the tumor, not around it. And the blood vessels are classically patent, thus avoiding all the complications of photocoagulation. So TTT is the current standard of care. What is new about TTT is photodynamic therapy using TTT. By using the simple indocyanine green laser, dye, you can do TTT on top of a tumor recurrence, as you see here, over a non-pigmented scar. So if it's a non-pigmented scar on top of which a tumor has recurred, there is no way a conventional TTT would take up laser. So there you use the advantage of synergistic advantage of using indocyanine green. Plaque brachytherapy is really not new. The indications are very well defined. It is very effective. You can see a macular tumor treated with plaque brachytherapy with very good results. But what is new is the availability of a regional plaque. It's very expensive to import plaque from the manufacturer, but the regional plaque made in India now costs less than 5% of the cost of an imported plaque from Europe. So this can now be available to the entire region, not just India, and can revolutionize the management of moderate size retinoblastoma and also malignant melanoma. So in focal therapy, what I said is what is used, and what's really on the horizon is transclearly usable strontium irradiation using a strontium probe and a chemoplaque that has been touted by Professor Brenda Galli. Chemotherapy actually brought about a paradigm change in the management of retinoblastoma. This was in 1996 when 4 articles in Archives of Ophthalmology, JAMA, then called Archives of Ophthalmology, brought out the advantages of systemic chemotherapy as a form of managing retinoblastoma. We used it very extensively, 3-drug protocol, carboplatin, etoposide, and vincristine, and got very good results. Chemotherapy has 2 principles. One is that it makes a large tumor small. the scar that you get is much smaller than the tumor that you began with, and tumor always shrinks towards its source of blood supply. For example, supratemporal arcade is the source of blood supply of the tumor, and the tumor has left the macula fovea and has shrunken towards its source of blood supply, thus freeing this crucial region for visual potential, maximizing visual potential. So these advantages we used and we got good results. But what is new is the other form of chemotherapy, other forms of chemotherapy rather, starting with neoadjuvant chemotherapy, adjuvant chemotherapy, intraarterial, periocular injections, epibulbar drug delivery systems, intravitreal and intracameral, all of which have become realities in the last 10 to 15 years. Hakan spoke about intraarterial chemotherapy, where we get into the ophthalmic artery ostium by using the services of an interventional neuroradiologist, and then we inject not one drug but 3 drugs. The conventional protocol was 1 drug, but to minimize the number of cycles of intraarterial chemotherapy and also maximize the efficacy, we combine melphalan with topotecan and carboplatin, which essentially have no additional complications than the complications that are associated with canalization of the ophthalmic artery, which can be spasm of the ophthalmic artery itself or some amount of carotid stenosis. Apart from there are no additional complications with these drugs, and these are very effective. As you see here, this child with total retinal detachment settled down with 1 cycle of intraarterial chemotherapy. You can see similar results here, very impressive results, but the cost is a barrier. Even in patients who have recurred, as in this case, a child who has recurred on top of a calcified scar, has resolved nearly totally with 1 cycle of intraarterial chemotherapy. In Group B tumor, we have 100% eye salvage. Group C is similar. Group D, 92% is eye salvage. Up till Group B and C, there is no real difference between intraarterial and intravenous, but the difference becomes obvious when we talk about Group D and Group E. In Group E, we have about 54% eye salvage, and the most advantageous way of using chemotherapy, intraarterial chemotherapy, is in recurrent cases. When we use it as secondary intraarterial chemotherapy, we have 96% eye salvage. So intraarterial chemotherapy makes a difference for Group D and E tumors, and also for large tumor recurrences following other forms of treatment. Vitreous seeds used to be a major bugbear in the management of retinoblastoma. Now we don't have just vitreous seeds. We have a whole host of seeds which are classified based on OCT under anesthesia, where we classify intraocular seeds as classic vitreous seeds, which we already knew about. Then we have prehyaloid seeds, subhyaloid seeds, epiretinal seeds, intraretinal seeds, and subretinal seeds, depending on the level of the location of seeds. And also intracameral seeds are further classified as depository and infiltrative. Depository are those who come through the zonules and settle in the anterior chamber, and infiltrative are contiguous extension of ciliary body infiltration of retinoblastoma to the anterior chamber angle. Now, what about just the vitreous seeds? How do you treat them? Vitreous seeds were conventionally treated with intravitreal melphalan. That is how the intravitreal chemotherapy began. It gave good results. You can see this 4 or 5 vitreous seeds that are totally gone after melphalan, which is good. But over a period of time, we started seeing complications of melphalan, especially in Asian eyes, pigmented eyes, in the form of retinal pigment epithelial atrophy. We also found a higher rate of uveitis, cataract. It needed weekly injections, making it logistically difficult for patients to take it, and also retinal toxicity. So for Asian Indians, I think for the entire region for that matter, intravitreal topotecan suits well, because we all have pigmented eyes. 30 microgram delivered 3 to 4 weekly gives excellent results. You can see that vitreous seeds is gone after 2 injections of topotecan in this slide, as you see, and complete calcification after 2 injections. When we have a difficult situation where the seeds are refractory, like you see here, this is how we began. This is after a few injections of topotecan. This after 6 injections of topotecan. It is much less than what we began with, but there is a bunch of seeds that are still refractory. Then we bring in a low dose melphalan. It is not used in the same dose as conventional. You can see some amount of RP changes here, but this bunch of vitreous seeds is gone. So when we combine topotecan with low dose melphalan, we have synergistic effect. So we use that in refractory situations. So topotecan is now proven to be very useful in the management of vitreous seeds. Now, extending indications. We have difficult situations when there are anterior segment seeds. Like here, you have a bunch of anterior chamber seeds. How do you deal with them? We can either give intravitreal topotecan, which can seep through the zonules into the anterior chamber, or directly intracamerally inject topotecan. It is not toxic to the corneal endothelium. You can see clear cornea with regression of anterior chamber seeds following intracameral chemotherapy. This is a patient with infiltrative form of anterior chamber seeding, where we know that the angle and the ciliary body and the iris are infiltrated with a bunch of anterior chamber seeds. Here we have to do it a dual form of therapy, where the ciliary body component is treated with plaque brachytherapy and the anterior chamber seeds are treated with intracameral chemotherapy. Now, for extensive epiretinal seeds, we used to do laser photocoagulation or transpupillary thermotherapy, which can cause a lot of scarring. But short of it, inject topotecan and the even epiretinal seeds can go away completely. This has been validated by Dr. Munier as well. He has a small series of cases, and this is our experience where we have used intravitreal topotecan for extensive subretinal seeds. In enucleation, we have understood the importance of long optic nerve stump. But what is beyond optic nerve stump and proper way of enucleation are the identification of histopathological risk factors, where we lagged behind. 20 to 30% was the mortality. Now that we identify that anterior chamber seeds, ciliary body infiltration, trabecular meshwork infiltration, and choroidal infiltration of more than 3 mm diameter or thickness, and optic nerve infiltration beyond the lamina cribrosa are the histopathological risk factors. And in those patients, we give adjuvant therapy. And the value of adjuvant therapy can be shown by this slide, where if we don't give adjuvant therapy, the 24% children succumb to metastasis. Just by identifying high risk factors and providing adjuvant therapy reduces mortality to less than 4%. So 20% of children, most children survive just by the pathological criteria of histopathological risk factors and adjuvant therapy, which is obviously very useful. Enucleation is not the end, as the dictum. In orbital retinoblastoma, we always used to have a problem in life salvage. Either clinical orbital retinoblastoma, where we see a proptosis, or radiologically diagnosed optic nerve extension, as you see here, had 70% mortality. Here we use multimodal treatment, where we begin with high-dose neoadjuvant chemotherapy. This is the orbital component that has resolved and the eye has gone into comfortable phthisis following neoadjuvant chemotherapy. At this point, we do either a enucleation or an extended enucleation with a long optic nerve stump, then give stereotactic radiotherapy to the orbit, and then give adjuvant chemotherapy as well. So it is 12-cycle chemotherapy plus surgery plus radiation. This is multimodal treatment, and that is useful for optic nerve extension. As you see here, optic nerve is involved right up to the orbital apex. Now, following neoadjuvant chemotherapy, optic nerve caliber has returned to normal, where is it easy to do enucleation with a long optic nerve stump and complete the rest of the treatment. This is anterior intracranial extension. We used to have 100% mortality. This patient has cavernous sinus involvement. Now, following neoadjuvant chemotherapy, that is gone, and what is left is in the superior orbital fissure that can be treated with stereotactic radiation. Of course, the child will need enucleation. The bonus is cosmesis. In patients with extensive orbital disease, we don't have to do orbital exentration, and the child can maintain good cosmesis following simple enucleation and radiation. So orbital RB also now has a cure. With all these added together, we have 95% life salvage, as we see in the West. 95 to 98% is what they see, all with cost-effective treatment modalities. And these are the aspects that are shown in red have actually affected the prognosis of retinoblastoma in our region. Neoadjuvant treatment for patients with clinical risk factors, adjuvant treatment following enucleation, and multimodal treatment for orbital RB have resulted in 95 to 98% life salvage. As far as eye salvage is concerned, intra-arterial chemotherapy, intravitreal and intracameral chemotherapy, and brachytherapy have resulted in 80 to 90% eye salvage. And in terms of vision, of course, these modalities plus ICG enhanced TTT have played a role in maintaining vision salvage. So in conclusion, I would say that management of retinoblastoma is complex, but the recent advances are very promising. Thank you so much.
Thank you so much, Dr. Santosh. It was indeed highly impressive, splendid presentation with a lot of information. Particularly, I felt really glad because it was catering to the residents also, because I'm sure among our audience, those residents would be, it would be more understandable to them. So I would we don't have any other question. I think we should proceed to our last speaker, Dr. Tayyib Afghani. So, Dr. Tayyib Afani, he's serving as the professor and head of Department of Orbit Oculoplastics and Oncology at Al Shifa Trust Eye Hospital, Rawalpindi. He's the current president of Pakistan Oculoplastic Association and OSP Ophthalmological Society of Pakistan Federal Chapter. He has received an award for his distinguished services and prevention of which is the Prevention of Blindness Award from APAO, Asia Pacific Academy of Oculoplastics. And to his credit, he has 50 publications. Sir, kindly proceed.
Thank you very much, Dr. Nausheen. Can you? Okay. Sorry. Thank you very much for giving me this opportunity. I'm really glad that on this forum, when we selected the theme, a comprehensive approach for eye cancer, we can hear now from the surgeons talk about chemotherapy, its dosages, and radiation, its dosages. We are actually, this is a very important change, and I really like that our surgeons and oculoplastics, we should be working on comprehensive approach.
And multidisciplinary approach, sir. Like.
Yeah, so my screen is now visible to all?
Yes.
Yeah. Okay. So the site survival and shape are at risk in eye cancer. Mostly trained as surgeons, we operate, while chemotherapy and radiation is administered by others. Eye cancer is low priority in oncology, and it's not among the 20 most common cancers in the UK, and it accounts for less than 1% of all new cancer cases. There are 120 cancer deaths, for example, per year in UK, as compared to about 12,000 cancer deaths from breast cancer. Oncology centers are overburdened from high priority cancers like breast, prostate, lung, and abdominal cancers, and eye cancer patients after surgery face long queues for further management. And most of the eye cancers, time is of essence. With this background, this presentation will talk about some of the issues that we are facing and what are some of the solutions. Before that, I will just present you 2 slides about the series of eye cancers in children in Al Shifa Trust Eye Hospital, where I worked in the last 20 years. You can see that almost 89% of the eye cancers in children is retinoblastoma, and about 5% is rhabdomyosarcoma. Carcinoma of the lacrimal gland, Dr. Mahbub has also talked about adenocystic carcinoma, yes, and lymphoproliferative, for example, precursor B-cell lymphoma, leukemias, etc. And neurogenic, we have this primitive neuroectodermal tumors and bony carcinomas, and there are miscellaneous. So this is the breakup of those tumors. 88% retinoblastoma, and about 6% rhabdomyosarcoma and other muscle tumors, and rest are about 6% of the rest. Now I will present to you with case studies. This is an 8-year female. I show you here a preoperative and a post-operative picture. We as a clinician, it's a good result cosmetically, and for the patient and for us. But the things do not stop here. Actually, the problems start afterwards. It's diagnosed clinically as rhabdomyosarcoma. Histopathology report was spindle cell carcinoma, which took 2 weeks. Parent reluctant for further treatment, counseling done, and finally referred to and landed in oncology center with systemic workup. Took another 1 more month. They missed 2 opportunities for the chemotherapy as family could not afford the cost. Applied for government support. That took another 1 month before it was approved, and the things started moving. The second study is 7 years male. Again, this patient is pre and post. You can see that we, as a clinician, we should feel happy. But the time, again, look at the timeline. 17th October, this was operated. 28th October, the histopathology was spindle cell rhabdomyosarcoma. And 29th October, referred to pediatric oncology center in another city, which is 350 kilometers away. And on 16th November, further investigation completed. So 8th December, chemo started. This is a third case study. Look at these two pictures. These are self-descriptive. Here you can see the same person in year 2003 and year 2007. It is me and I can see, you can see me standing amongst the family of retinoblastoma. And here you can see this is the father. These are the children. This is one patient of retinoblastoma. This is another patient of treated retinoblastoma. This is the third case of retinoblastoma with spontaneous resolution and having thighs. Now this child again married. And now the grandfather again proudly comes after in 2017 and shows her grandson again with the retinoblastoma. Despite counseling, despite all the risks told and shared with the family, I mean, they somehow could not. I mean, it's the marriage, the inter-family marriages. These things just continue. So this is another very important aspect of social problems about retinoblastoma and eye cancer in children. Case 4 is an optic nerve tumor in a 3-year child. 3 months prognosis, showing large optic nerve tumor. Family history of brain tumor, deaths of father and uncle. First biopsy, and later we have to do exenteration. Child is tumor free with 2 years follow-up, fortunately. Optic nerve tumor, what was it? First histopathology report was anaplastic meningioma, grade 3. Second report after exenteration was myofibroblastic tumor from one center and histiocytic sarcoma from another center. Fourth review report was finally histiocytic sarcoma. And what we did was, based on the last review, the child was advised radiation, but single mother, because her husband has died already of a brain tumor, refused for any further agony. Surprisingly and fortunately, and to the relief of mother, the child is tumor-free after 3 years of follow-up. So what are the issues and challenges? Some of these issues and challenges have already been talked about by Dr. Ben Limbu in his presentation. Dr. Ashok Grover has also talked about it. And Dr. Santosh has also alluded to some of those problems. Is a delay in diagnosis and treatment of cancer increases the mortality. There is no doubt about it. We found it to be either system-based delay or parental delay. Cancer treatment costs are many times higher than treatment for other common health conditions, and government support is very much minimal. Specialty services in ocular histopathology are non-existent. That delays and at times miss the accurate diagnosis we have just seen in one of the cases. And then cancer is a stress for the family and for the patient as well. You can see that here that cancer is one of the top most cause with traumatic stress symptoms after. This is about 1/3 of the parents and 1/4 of children had this. And this study was a research finding from Children's Hospital of Philadelphia. So this is another issue. This is rehabilitation. The next issue is rehabilitation. These are the two pictures which I am showing you here, but these are two different stories. The female, the lady is actually a retinoblastoma survivor. That is the original picture. And the other is taken from the net. The lady was a retinoblastoma survivor, and she had requested, after becoming blind from both eyes, that when she was a child, she underwent enucleation and all that, and now she wanted, after a couple of years, that she wanted to have blue eyes. So our ocularist agreed, and then she provided with these beautiful artificial eyes. So this is another, what the patient wants, and whether it's cosmetic concerns of the patients have to be looked into. And then the other picture is that of an exenteration prosthesis. So how much this is common, how much it is available, what are the difficulties with that is another very important. And rehabilitation becomes an important component of the comprehensive approach of eye cancer in children. So genetic counseling and family support is in our setup is an important social and technical challenge. We have seen families break up after the counseling is provided. I know a patient family came first with the father and the mother and the retinoblastoma child, and then when they were told what are the chances of having the retinoblastoma in the next children, Next time, only the mother came with the child and the child's grandfather. The husband has divorced her. She was left to stand on her own. So eye cancer, and this thing has also been discussed in today's forum as well. That's another issue. Health education at policy level. The policymakers are not very much aware about this. Public level, professional level, and parental level. That's all needed. That's very important a step for, and Dr. Noshin has also talked about in the beginning. So a summary of the challenges is that the issues we face in management of eye cancer is parental delay and compliance, system delay, diagnostic dilemmas, cost of cancer therapy is very important, family stress, disfigurement, rehabilitation, non-existent genetic counseling, and lack of health education. So what is the way forward? This is we worked on this for the couple of years. We worked towards to develop a comprehensive eye care center. In this picture, this picture at the top is actually the premises where the Center for Eye Cancer is now being developed. And this is my hospital, Al Shifa Trust Eye Hospital, Rawalpindi, which is one of the center of excellence in the country. And here we are developing that approach, a separate premise for Center for Eye Cancer with the following additional facilities. For example, general pediatric oncologist who has been hired for a minimum of twice a month visit to conduct chemotherapy, an oncology nurse to assist the visiting oncologist for chemotherapy, and an ICU and a 4-bed ward for patients undergoing chemotherapy. An oncology coordinator. This is probably the most important. We found this fellow as the most useful person to hire. This is coordinator or cancer social worker whose sole job is to look after the eye cancer patients after they are operated, get them earliest appointment for radiation, because it's very difficult to get appointment for radiation as well as chemotherapy at the general hospitals, cancer hospitals, and then to arrange for transport and arrange for funding where needed. A trained clinical psychologist for patient and the family is also there, and an ocularist for the basic rehabilitation. So far, this is another issue. Ocularists they're not formally trained. They're just technicians who turn into ocularists. And we are working also to make it a institutionalized education program. So in the next 2 years, we plan short-term training in ocular oncology, a certified training program for ocular histopathology and provision for genetic counselor, and certified training program for prosthetist with emphasis on ocular history. And the next phase, although it is trying for moon, but we have put our management is really very much with us that inshallah in the next few years, we will also develop radiation therapy facilities at Al Shifa Trust Eye Hospital. So we have at the moment, I will talk a little bit of successful advocacy which we carried out. Side by side the development of comprehensive eye cancer, we were able to convince our national policymakers to make eye cancer as part of our 5 years national program for prevention of blindness for the first time. It may be mentioned here that Pakistan is having regular 5 years national programs for prevention of blindness for the last 25 years. And this is the first time that eye cancer has been given a focus in its current 5 years program. So in summary, 90% of eye cancer in children is retinoblastoma, 6% rhabdomyosarcoma, and rest are 4%. As an orbit and oculoplastic surgeon, a job does not finish after doing eye cancer surgery. System, parental delay in instituting adjuvant therapies result in increased mortality. Provision for chemotherapy with the help of oncologist and oncology nurse at an eye facility is a viable option, and cancer social workers, psychologists, genetic counselors, and ocularists are essential components of comprehensive approach. Thank you very much.
Thank you so much, Dr. Tayyab Afani. You never ceases to amaze us. It's always a pleasure watching your presentation. So with this, we comes up to the end of our webinar where all the speakers are done. I would like to introduce our panelist, which I've already introduced, Dr. Santosh Hanover, and Dr. Rohit Seju, and Dr. Moin is left. So Professor Moin is the is serving.
Okay, let's Dr. Santosh and Dr. Let Dr. Ghulam Haider, Dr. Santosh, Dr. Grover, they're all on the panelists and they can take up the panel discussion if there are any issues left, because we are already about an hour late. So I think we should, this has been a wonderful session. We are really enriched by source of a lot of information. And I think I will request Dr. Santosh, Dr. Damirji, and Dr. Ashok Grover to kindly come over and let's have just few minutes of any burning issues which you like to talk about. Everyone, all the panelists can join.
Dr. Santosh, please unmute yourself. All the panelists, please unmute yourself. I would only begin by saying that this has been a very, very useful session. I think it has not just highlighted the technical aspects, but the problems facing the region, which include not just the availability of services at a wider level, but adequate sensitization of the authorities and the financial aspects of patient being able to afford it, and therefore the delayed availability of treatment. And I think what Dr. Afghani has presented is wonderful, the kind of advocacy that he has been able to do and get the facilities for the center. I think we need to create many more such models, and we all need to be learning from each other to create such models. With that, I'll hand over to Dr. Moin, Dr. Santosh to please carry on with the discussion on technical aspects.
I think it's been a wonderful presentation, and the Professor Tayyib Afghani has done a great job in organizing all these speakers and then obviously engaging them in the session. And let's see, just turn this. Okay. And I think with this forum set up, I think this is an opportunity that we can start some collaborative research in the topics of retinoblastoma. I think Dr. Santosh is doing such a wonderful job in the region that we can definitely get help from him and sort of start some research on the forum of OPASA, which can help us sort of make our data more robust and sort of more acceptable to the international organizations. Because some medicines are available in India, some are not available in Pakistan. We can discuss on mechanisms, how those can be sorted out. And especially chemotherapy is one thing, especially even in other treatments such as rhabdomyosarcoma. If those are available, then we can sort of do wonders with them as well.
Yes, Dr. Santosh, if you have to say anything about, add anything to the problems of the region or whatever is in your mind regarding the comprehensive approach.
I think the outline that you gave was wonderful. In fact, that is what we had done at LV Prasad Eye Institute when we started ocular oncology. There was no such subspecialty. So we started off having an oncologist, medical oncologist come over and provide chemotherapy services in the eye hospital premises so that patients don't have to run around. Then the next thing that we did was standardizing histopathology reporting using international protocols. Histopathology has to be reported in a specific way. Callets have to be cut in a specific way. All that was standardized. And then we added genetics. So bit by bit, and then ocular history. So at the end of 5 to 6 years, you can build the entire department. Chemotherapy is not a big problem. Giving chemotherapy because these are safe drugs, but we should definitely have expert nurses to do that and somebody to monitor chemotherapy side effects as well. So oncologist's role is critical. Radiation is now possible within the region. We don't have to import a plaque. The BARC or Bhabha Atomic Research Center plaque is available to all the countries in the region. It's gone for a CE certification now. So after that, it can be exported to Europe as well. But for the region, we don't need CE. We can export it even without that. So they are willing for providing these plaques at a very concessional rate to the entire region. So you can explore that possibility.
Thank you very much, Dr. Santosh. It was a pleasure to have you around, and it was nice to hear you. Yes, Dr. Demirji, if you want to add anything, it is a real, we are really happy. You know, you are around, and this, where the time
Yes,
to
and
sleep.
we can see the sunrise and the and the snow.
Snowing. Dimitri and me.
Yeah, a snowy morning, snowy and chilly morning.
Thank you very much. I mean, this was a great, this was a really, really good webinar. I learned a lot personally, and then it's so well organized. And anything I can do, please don't hesitate to contact me, basically. So, but
it's really sweet of you, Dr. Demirji.
Dr. Demirji, don't worry. We will have a lot of planning for you, inshallah.
Thank you. Thank you.
Thank you very much. It was a real pleasure. You know, I am really, this is a commitment that you showed, that at the middle of the night, almost, you know, time to sleep, and on Sundays you are awakening. Thank you very much. Dr. Amar Yaqub, if you want to say anything.
No, it's been a pleasure attending this seminar. The presentations have been excellent, and the interaction has really increased my knowledge in a number of areas. So I think we should have this interaction more frequently and as much as possible, with the various countries organizing these webinars as much as possible. Great, thank you.
Dr. Ben Limbu, you are around?
Yes, I'm here, yes.
It was a pleasure. Dr. Ben Limbu, I really enjoyed you have done a wonderful survey. And I think I don't think it has been published, or is it been published?
No, the book has been published, but report has been published, and then it's going to be scientific publications are on the way. There may be 4 or 5 publications out of this study.
Okay, that's good. I think it will be an important, because we have the same problems in this region, and then we can learn a lot from your survey. And Dr. Ghulam Haider, our great surgeon from Bangladesh. Do you have to say anything? You have already, I can see that you have changed over to your clinic dress now.
My clinic now.
Good evening.
My practice is going on. Patient is outside.
Yeah,
outside
sorry, I'm not keeping you much. I'm sorry that, and you did manage from 2:30 to 6 o'clock in Pakistan time. This was a great.
No problem. It can happen. It can be happen. It can be happen. No problem.
Okay.
Especially, I thank Pakistan Occupational Association to end the seminar with OPSA in time. And again, I giving thanks our guest speaker, Rakam, and then Dr. Santosh Hanova. They're delivering excellent lectures that we are benefited from them. Now, on announcement for all of us, next April, 4th April, India will arrange, India Global Society arranges OPSA, the next seminar, next webinar, 4th April, remember. Thank you all of you.
Okay, thank you very much. And now we are coming to the end, but before that, a person is not mentioned so far who has actually worked behind the scene to make this webinar a success, and he is a silent worker. He is our assistant.
This was my next.
Dr. Sadullah.
I was about to.
He has done a wonderful job to make this successful, and he is a very shy person. I request him to please come on to the screen and at least show your face to all the worthy speakers we have learned this webinar system right in the last 15 days, and he has done a wonderful job.
Wonderful.
Thank you, Dr. Saad. Where are you? Are you listening?
Yes, he's here, sir.
Unmute yourself.
Please unmute yourself and show yourself. Identify yourself, please.
Thank you very much, sir. Thank you very much.
So this is Dr. Sadullah, who is our assistant professor, one of the senior assistant professors, and he is also trainee in the oculoplastics. He is also the student of Dr. Amar Yaqub as well as my student. So it's a pleasure to work with him, and it was a great job done, Dr. Saad. Thank you very much.
I would like to, in the end, I would like to thank all the audience as well, everyone who joined us and supported us. I'm really grateful to all of them that they gave because without them, we couldn't have accomplished our task. Thank you once again, and thank you all the team.
Thank you very much, Dr. Mosheen. You have done a wonderful job to run through the meeting, and
Final
request
thanks
Dr. Ashok to at the end to
Pakistan.
please give a vote of thanks.
My final thanks to Pakistan Oculoplastic Association for having organized this session for OPSSA, and your team has done a wonderful job technically and in planning this session, and the result has been one revelation where we have really discussed the issues that we wanted for the region. It will result in much greater cooperation, not just in academics, teaching, but as also in providing better coordination in clinical treatments and also in the research protocols, as Dr. Moin mentioned. I think we all look forward to this forum working together to provide better oculoplastic services to our region and better oculoplastic training in our region. Thank you all very much. Thank you, Pakistan Oculoplastic Association again. I would expect all of the speakers and all the panelists today to become members of OPSSA. Let's make it a very vibrant organization. Thank you. Thank you again.
Thank you very much. So, Dr. Mosheen, we can now wrap up the meeting, and everyone is eager to have a cup of tea and go back. So thank you very much indeed.
Thank you so much, Dr. Mehboob also. Sorry, I had to interrupt Dr. Syed Mehboob. I had to interrupt him because we were short of time. I felt bad, but that was at that time.
Okay, thank you very much.
Thank you so much. Take care.
And see you again on 4th April.
Allah Hafiz.